about it, I think it'll be night, so I thought I'll stick to one slide. So everybody, I think here doesn't need an introduction to Dr. S. Natarajan, but we would like to tell you that it's the 30th anniversary of Aditya Jyot, but 100 years of ophthalmology has gone through the family of Dr. Natarajan because his grandfather, his father, and himself have been ophthalmologists. And over the years, he has taken ophthalmology in India to another level. So he has, of course, trained at the famous Shankar Netralaya in Chennai under his mentor, his guru, Dr. S S Bhadrina, who everybody knows. And from there, started a journey of 36 years or more in the vitreoretinal surgery. So he has performed over more than 60,000 exclusive vitreoretinal surgeries, probably more than anybody else right now around the globe. And he is not only an innovator but also a great teacher to all of us, and he has been imparting knowledge since he's initiated his Aditya Jyot in the 90s. Today, he is recipient of multiple awards. Most honorable is the Padma Shri Award, which he received a few years back. And he's always on the move. He moves all around the globe, and I think no one who is in ophthalmology doesn't know him, and he teaches everyone. And I am glad and honored to be one of his students. And I would invite him to talk on this journey of Aditya Jyot in the past 30 years and what we have achieved in the field of ophthalmology. I welcome Dr. Natarajan.
Thank you, Jaideep, and thanks a lot. I want to thank all our speakers today, Dr. Jyot Mehta, Dr. Rohit Shetty, Dr. Tarak Katamesh, Dr. Gangadhar Sundar, Gavin Tan, and my good friend John Prakash. And apart from that, we have our own Aditya Jyot faculty, and specifically my Karma Bhumi. We have the President and Secretary of Maharashtra Ophthalmic Society, Dr. Sunena Malik, Dr. Vardhaman Kankaria, and the entire, I can see KL now, entire Maharashtra, and also Bombay Ophthalmology Association. We have Dr. Pritam Samant, President, and I have the great opportunity to work with him when he was the Secretary of BOA. And then we have Swapnesh Sawant, who is also known to me from his earlier days. So, and then all my friends who have joined, and thanks to the I should say thanks to the entire world. I believe law of attraction, like Dr. Bhujang Shetty and Dr. Rohit Shetty. I'll share my screen now. So I think I was just telling when we were getting together that God chose 3 hospitals in 1990. That's the serendipity that we had to. Aditya Jyot Eye Hospital was born in 1990. And Singapore Nationalized Center, that's by the government of Singapore, and St. Eric's Hospital, Karolinska, again by the government. So ours was, I started as a proprietor. Now we are a group of ophthalmologists. It's a private limited, and I'm glad to share the journey of Aditya Jyot. And I wish, this is what I learned from Dr. Badrinath, that I wish we have Narayan Netralaya and everybody here, that we have more institutions. We have 1.3 billion people with 2.6 billion eyes to treat. So the beginning, we have I think I learned all this, and I've seen even Dr. Bhujang Shetty when he started as Narayan Netralaya, and plus Shankar Netralaya was started in 1978, L. Prasad in 1987, and Arvind Eye Hospital in 1976. And because I'm a third generation ophthalmologist, I could see all the things growing, including I had a good interaction with Dr. L.P. Agarwal from All India Institute, who made the visionary for the RP Center. So everybody had a vision, and I always tell this, and I remember discussing with Rohit also, that all of us as an ophthalmologist should have a vision, apart from giving vision to the people. And we are in the year of 2020, and it's really like a mixed feeling. And I think when the year 2020 began, in the Tamil TV channels, the entire they were scolding, actually literally scolding the astrologers who predicted this will happen, that will happen. And I think we had our Vision 2020 document signed by WHO and IAPB in 40 years back. And that time they said everybody right to sight. And that's what was IAPB statement. And Dr. Kalam during his visit also mentions that in the hospital. And everybody had a vision. But I think in spite of all that, the corona has made it's called the disruption. And I think it has disrupted us. But I think we all have a clarity of vision. And when we have excellent refractive surgeons here, many of them. And I think we have to have a clarity of how the patient expects 20 by 10. And same thing I think we expect. So we all have a vision, a goal, a plan. Finally, you have to do action, and then finally success. So this is what we learned from Shivanandan and Bowman Irani in the morning. What is called as progress, growth, progress, and success. Growth is going from 5 crore to 500 crore to 5,000 crore. And progress is doing it with morality, with good morale, and success is with doing it with the spirituality. And I'm glad Dr. Rohit Shetty in his hospital is bringing how we can have all the 4 dimensions of good health. So I have made a 3H thing now. All of us should live happily, healthily, and holistically during this COVID. And that's why I call it happy times. The foundation stone of my journey was laid with my blessings of my late father, Dr. N. S. Sundaram, who was an ophthalmologist from 1955 till 2015. He worked, and my mother, who gave me education, my guru, and everything for me is Dr. Bhadrinath. And whatever I am here today is because of him. And I respect him and I salute him today. And I'm glad the man who made me a retina surgeon, and right from 1851, Helmholtz found the direct ophthalmoscope. And then till 2016, the American Society for Retina Specialists has made a Retina Hall of Fame. And who's who in retina from 1851 to 2016 are called the charter members. I'm glad my teacher and the student, I'm there. I'm still, it's like a dwarf standing on the giant Dr. Bhadrinath. And that's what Isaac Newton said. And for me, Shivanandan is everything. He's my parent, grandparent, now for me, friend, philosopher, guide, and finally God. And I think the word Aditya means sun god. Aditya gives sun, and without sun, nobody can live. And sun gives light to the world. And Jyot is lamp removes the darkness around. And that's my grandmother, who was there in the morning celebration with me whole day. She's 102 now. And every day I do Shashtang Namaskar. And that's my grandfather, who passed away in 2003. And this is how the first Center for Retina Vitreous Surgery and Research, similar name to Steve Charles, was started in 1990. You have Dr. Sunil Parekh there, who is a consultant. And this is my grandfather and grandmother, where you see Dr. Bhadrinath, who was the chief guest, and Dr. Gulapalli Rao was the guest of honor. And we had the Nana Chudasma, who was the sheriff of Mumbai. So one step must start each journey. And one day a chairman from Bank of India was impressed with his wife's treatment, which I did. And I'm glad that even though I started, when I came, I always said I came alone, but now I have a big team. And this is my Karma Bhumi, that is Mumbai. So I'm a Mumbaikar now. And that time in 89, I came in 88, started working in Aditya Jyot Eye Hospital. And now in 89, Lahiri joined. I'm happy she's here. She's a consultant still in Bombay Hospital and head of the department there. And she was the witness to this. And that's how I got my first loan from a chairman from Bank of India and started Aditya Jyot Eye Hospital. So the main problem was I could not do everything what I wanted to do in Bombay Hospital, because they promised me they will give me whatever my second mentor, Dr. Rajat Jovanovich, who was called the father of modern vitreoretinal surgery, whatever he had, like specifically the Ikakami camera and all the micro instruments, then they could not give me. And that's how, because of the frustration, I think creativity was which happened, and that's how the Aditya Jyot was born. If I was happy in Bombay Hospital, maybe I would have continued and Aditya Jyot wouldn't have born. But I'm happy that Aditya Jyot was born. And you can see that's the building in the ground floor. I remember taking Dr. Bhadrinath around the beginning of March 90, because at the time I resigned from Bombay Hospital. But I worked 3 months with a 3 months notice. Dr. Lahiri was really helping me transition from Bombay Hospital to Aditya Jyot. And she was a fellow with me in Shankaranetla, but later she became clinical assistant, and now she's the consultant. And that's the foundation stone being laid. and we inaugurated on July 15, 1990. And again, Dr. Badrinath inaugurated the LASIK in 2001. You can see Dr. Shujalsa, who started the refractive surgery. Kuresh Muscati is there. And thanks to Kuresh Muscati and Dr. B.T. Muscati, who was the responsible for me to come from Chennai to Mumbai, where they said after the All India Ophthalmology Society conference in 1988 in January, that's the time Steve Charles came first time to India, and I was there as a because Dr. Badrinath did not come for some reasons, and I had the special prize for my video. First time I think ever a vitreous surgery was shown in an All India conference. So that was in '88, and we had the first endo laser in '86, and I showed the video on foreign body, and that's how Vatsal Parekh came and joined as a fellow, and that was I think a great memory. Even now, I look young that time, and again I'm really young now, and this is how the other looked, and now there's. And they always Shivanandan said, you should have a big building, you should have a facade, you should have an exclusive building, and it happened in 2004. I think constantly you need somebody to push you, and that's Shivanandan for me, and that's how the institute grew, and we are now, I think, one of the first few institutes in Mumbai with a multi-specialty in all the subspecialty in ophthalmology. Thanks, now we have the entire program is totally, it's the brainchild of Dr. Kavita Rao and Dr. Jaydeep, and they are probably looking a little elder to me, and I think know these things to Kavita, but I think I'm happy because I'm working under them. So that's how I'm happy, and this is how Dr. Sushil Kumar Shinde, who was the then Chief Minister who inaugurated, we had Aishwarya Rai inaugurating the Aditya Jyot Eye Bank, and she does a great thing, and she always supports as an eye bank, ambassador to Eye Bank, both for the Eye Bank Association of India as well as the Aditya Jyot Eye Bank, and now Dr. Kavita Rao is the director of the Eye Bank. And we have all the subspecialty. We have the 4-floor state-of-the-art equipment, and this is the old logo, and that was a triangle. And then we opened up, and the 20th anniversary, where we have the 7 colors of rainbow: the WebGR, violet, indigo, blue, green, yellow, orange. And I think as ophthalmologists, we know you mix all the colors, you get white, and that's white means purity, and that's what Aditya Jyot is. Aditya is sun, giving light to the world. Jyot is lamp, removing darkness around and removing ignorance around, and that's what is our All India Ophthalmic Society also is from darkness to light, and which is there in Sanskrit also. And we were happy to be ranked #1 in Outlook magazine. And I remember in 2002, the same thing, we were ranked #5 in India, and we were ranked the #1 in cleanliness in India. And I still remember Dr. G.N. Rao and Dr. Badrinath said, how did you get it, man? I only told them the size of the hospital is small, so I could keep every millimeter of the hospital clean. And thanks to Reader Digest, who recognized as the most trusted eye hospital, this is by patients giving the voting, and I'm happy that we are continuously in the 3rd consecutive year, and thanks to all the patients. And I think I always tell this in every conference, because as an All India president last year, I addressed 91 conferences in 52 weeks in 15 countries, and maybe 78 or 79 cities in all. So I think again this was in the top 10 again in the Reader Digest, and this is in the week in the 2017. I'm glad all this are being done, and we are happy. Dr. Abdul Kalam came as a president. He sent me a child, both eye injured. Asked me. I used to meet him like a friend in the Rashtrapati Bhavan, in Raj Bhavan, in airport, wherever. I mean, whenever he came to Mumbai, I told him. I told Dr. Badrinath, and that whenever he visits Mumbai, he should visit me. Same thing I told the president, and he did it. In case he cannot visit, he will call me, and I'll go and meet him. And he was a great friend all the time, and that's why every day I have 4 gurus I remember: Dr. Badrinath, Mr. Shivanandan, Dr. Abdul Kalam, and Dr. Aditya Jyot Eye. And they are in the heart and the soul all the time. And he gave the name Aditya Jyot Foundation for Twinkling Little Eyes. He always told me, like the Little Heart Foundation, he was a patron for Aditya Jyot. He said, why can't you put a little twinkle in every eye? And when I showed him that fundus on phone where the illiterate boys can handle taking the retina photograph, he told me, will the fellow will not harm the eye? I said, no, sir, it's totally non-touch technique, and the boys will not injure. So he was so careful. He made the oath for ophthalmologists. And this is Selena Jetli, You can see Shivanandan is there in the thick and thin with me for every, and this was again promoting eye donation in 2009. And Dr. Abdul Kalam again with Dr. Shivanandan opening the van in when 2012, when I called that mobile. I accidentally wrote a mail to him, kindly inaugurate the ambulance. And he immediately called me and scolded me and said, Dr. Natarajan, when you have equipment in the van, it is not an ambulance. It is a mobile screening van, he told me. And I remember that very well. And his secretary also made sure that it's called a mobile van. And this is a mobile diabetic van, which was screened, where we have the size camera even today. And we also have the size laser. So our doctors do here. You see Dr. Radhika, Dr. Sunita Mohan, Dr. Navendu in the picture. And Samita also was there, which was recently there, who's now the faculty in the group. We were the first one to do the forest camera in the motorbike, which I borrowed the idea from Pizza Hut. Why can't we deliver healthcare at doorstep? And that's what we are doing with the forest camera. You can see my father, my grandmother inaugurating the mobile motorbike, and where we have Ravichandran and Dr. Radhika there. And we have introduced a lot of technology. I'm happy that Dr. Badrinath gave me the training to think ahead, think out of the box, because he always told me, I learned everything from Dr. Skipens, and Dr. Skipens also visited me. I'm a Dr. Skipens student is Dr. Badrinath, and Dr. Badrinath student is me. But I'm happy we're all three in the same Retina Hall of Fame. So we started doing the sutureless scleral buckling. We did the using the retinal endoscope, preferential hyperacuity perimeter, and also the biome. And the greatest contribution done by Spitzner in 1987, which was published in German journal. And later, I think probably I popularized world over in 90. And we also started the microvitreous surgery along with the Mark Kumar in first. And I think a lot of India, I'm glad that we are growing with the technology. And I also want to tell all the young doctors in the group, as well as who are watching, whatever I learned, I think you have to unlearn and you have to do something. And that's why I think nobody will remember, but I very pleasantly remember in 2011, I celebrated 100 years of an ophthalmologist getting Nobel Prize with Rohit Shetty and none other than that. And I put one slide saying that one day Nobel Prize for medicine in ophthalmology we should get from India. And I hope, I'm sure I'm seeing Rohit as my mentor there. And I'm glad that I introduced the 3D digital using the RTO, and I love that because I can teach. I'm glad. The first day when it came, I told whoever the faculty wants to use it, and even I'm ready. Even the students can use it, and we use the RTO for all procedures in ophthalmology. So we also have academic program, we have fellowship, we have a DNB, we have optometry. So vision is to achieve international excellence in ophthalmology, and vision is to enhance ophthalmic and visual science in the country. We have a fellowship in general ophthalmology, cornea, medical retina, surgical retina. We also have the fellowship National Board Retina with the Maharashtra University of Health Sciences, then optometry training. We have trained more than 1,000 eye doctors and 68 retinal surgeons all over the world. We have fellows who are faculty, who are doing live surgery. I'm glad many of them have excelled me, and that's my blessing to them. And it's a great if Dr. Jaydeep as a retina surgeon excels me, and he is excelling already. And we have the Aditya Jyot Institute of Vision Sciences and Research, and we promote research. And I think we also, as an editor of Indian Journal of Ophthalmology, we made a special journal of transferring technology from lab to the clinical, and thanks to Rohit, who was the guest editor and did that time. And my interest is working on artificial retina, even though it's not doing well. I worked with the IIT for 5 years. I failed, but I like Thomas Alva Edison and the others who have failed in several research projects. I think I failed even today, but I hope, like Dr. Abdul Kalam said, he likes the waves in the sea just because it's not rising every time, but it's rising after every fall. I've fallen down in this. I hope one day with any of this, with the help of other institutions, we tried working with the National Brain Research Center, IIT Mumbai, Bombay Veterinary College, and now we are establishing clinical trial network with Dr. Gopal Pillai and the Government of India. And we also did a lot of work with so many things and Bombay Veterinary College. And it is like sometimes looking like going and banging your head against the rock, but doesn't matter. I think I have several projects I tried doing with Rohit. I have failed, and every time it's like a slippery rock, and I'm falling down. Now also I'm down again. I have to climb, and then other thing is stem cell. Where again, so many things I tried, nothing is working, and we are running the Institute of Optometry. We have a wet lab for biome. We are also having wet lab for the regular students, and we have a library. And this is a picture now, Lakshmi, who's probably looking more prosperous. And this is her look in 2003. She was my academic secretary who manages. So my inspiration constant is Saint Thiruvalluvar and Swami Vivekananda. And Swami Vivekananda is there. They both are there in the Vivekananda Rock Memorial in Kanyakumari. And he always mentioned, arise, awake, and stop not till the goal is reached. One more thing I learned from Swami Chinmayananda, keep changing the goal. That means every time you achieve something, don't stop. And today, Shivanandan advised, okay, you climbed the Kanchenjunga, you can climb the next peak. You climbed one peak, and I saw in one of the TED Talk that you keep climbing peaks. So that's what I want to tell to all the young ophthalmologists who are just finishing. And I hope if the young people who are finishing MS or DO or DNB this year, and if they have not listened to Sundar Pichai's the graduation ceremony, which he says, I'm talking alone to the YouTube, which he runs the YouTube, and he says that I'm in the garden, I don't see any audience. And the same thing here. He said exactly the same as during the 18-19 pandemic with the Spanish flu and post 9/11, and in this COVID pandemic, we have graduates graduating and doctors who are beginning their career, and profs, all the established hospitals like mine and Dr. Rohit Shetty. I asked him, how is the situation? He said, we are sailing. Yes, we are sailing in a rough storm in the middle of the sea. Don't give up. And I think be happy, happily face it, enjoy like the life of Pi. And he says, he learned spirituality, the life of Pi. That boy says to the tiger, you have to live, I have to live. If I sleep, I'll become your food. So if you sleep, I can sleep. So same thing here. We are in the storm. Be bold, stand up, be bold, be strong, take the whole responsibility on your own shoulder and know that you are the creator of your destiny. And this is what Swami Sukhabhadananda says. And I take this opportunity to thank Kavita, Jaideep, and all my fraternity who worked with me. And I can see Rupali, many others, right from 84 in Shankar Nethralaya, and before that in Government Ophthalmic Hospital, my school, my college, because I have teachers right from my parent, grandparent to now. And even today, I keep learning. Thank you very much for the opportunity and for the time given to share my journey into our journey. And now onwards, we have another 30 years of journey together. All the institutions who are there in the panel today and who are not there. Thank you very much.
Dr. Natarajan, for this wonderful motivational journey.
Thank you, sir.
Thank you for taking us through the I just want to share the slide for the next speaker. But meanwhile, Jaideep, if you have any questions for the panel.
Well, I think it's really an inspiring talk for all of us. And as far as questions, I don't know whether
more than questions we ask. No, more than question, but I can probably ask Jyot and Rohit to make a comment or advice to the people. Rohit?
Sir, you mentioned in your talk today that you always want to see out of box. The only one-line inspiration I learned from my chairman, and I keep quoting it all the time, is he said, never see that there is a box. In the box or out of box comes to people who want to confine themselves to a particular set of thinking. And to be very frank, all achievers today, indirectly or directly, if you really see their journeys, including yourself, I'm sure that none of you looked that there is a box. So I would like to, if there are a lot of your own young team listening, and if there are people listening, I think the only way to success today in the new normal or old normal is to see that there is no box. Then your line, what you mentioned about Vivekananda in the last, that there is no fear if you really don't see a box and confine yourself. Wonderful journeys, wonderful, always inspiring, and what makes you so good is that you're humble, and you make sure that you teach humility in all your presentations, and you do not shy away from giving credit to anybody. Sometimes it's more than necessary, but you do give to every single person, and your posts also show that it is important in all this being busy in life. It is very important to take care of your people, your family, however old they are. In a small way, you're teaching the younger generation to take care of your parents.
Yes.
I mean, we don't need anybody to say that, but still, in today's world, as people are getting older, your life take more precedence than everything else. Your job, your career. You ask me what I learned is that you need to spend every minute with people who may not be there tomorrow, and in a very subtle way, you teach that very well. And all your teachings are not teachings; they are actually you lead by what people need to follow without asking us anybody to follow. I think that is a true sign of a leader.
Thank you so much, Rohit. I think I learned something today, because I remember Dr. Badrinath, Shivanandan all the time tells me, don't quote Robin Sharma, don't quote Swami Vivekananda. You yourself is better than him. I don't agree with that, but I think Swami Vivekananda is all the time I carry also. So this is Swami Vivekananda. So all the time it's in my pocket. So today I decided I have to be the same normal what I was in 1990. That's why I wore the full suit, as Kavita said, and I'm like wearing the socks but not the shoes inside the house. And my grandmother was there in the morning. I agree. And thanks to Rohit for highlighting that point. One thing I learned from you is no box. I think even though I'm doing that, but I was a copycat and trying to copy somebody's sayings. And I can see Dr. Sunaina very intensely listening. And I want to remind Sunaina, I was a fighter cock in Maharashtra Ophthalmic Society in 90 to 94 till I got an award there. Because I said, why I cannot get an award? Everybody told me you're too young. I said, doesn't matter. I said, I deserve it because so many things I've done. I remember fighting in the Aurangabad conference in 94. I still remember Dr. Anil Kulkarni taking me aside. So I want that people to do that. And I'm happy Kavita does that to me, and Jaideep does that to me. It's good. I think we should have healthy arguments. And I'm glad I told that there's no box, and I agree with that. Without that, I think we have done that. And second is, I think this grandmother's thing, I was just putting with love, nothing else. But I think it's everybody in the world. I think she is more popular than me in the Facebook. And I think everybody will ask me, how's your grandmother? I think not only whether it is Subar Huang or Steve Charles, anybody, how's your mom? They'll ask me. I said, it's my grandmom. Oh God, how old is she? She will. I think I'm glad. I think I spontaneously put it. I think I write whatever comes to my mind. And then many times Shivananda will say, if you are doing something, you're like you're taking your phone and your location is on. I said, my life is an open book, and whatever photo I take, it's automatically in the cloud, and anybody can see it. So I say that. So I don't. This is what Shivanandan taught me in 2005. When you are a public person, even in your bedroom, your life is public. So I use the word bedroom because I think you have to stand by example. You have to practice by example, not by. So I think I'm happy. I'm able to do that, and glad you highlighted that. So I learned that something about that, and I hope, in case whatever I have done to my staff, please forgive me. Sunaina, you want to say something?
Yeah, I would like to say that I have been witness to Nati's journey actually. What he mentioned from Bombay Hospital, he and Karobi and we remember that time. I had gone there for a course in extracapsular cataract surgery, and he had just joined Bombay Hospital. And I can never forget, I used to join him for his surgeries in the afternoon and find them so boring, because at that point of time, There was no observer microscope. So I couldn't see anything of what was going on. I used to wonder what this guy keeps doing in the eye, which only he can see. Because we are anterior segment surgeons, and at that time, posterior segment surgery was an enigma for us. But I admired his persistence and the way he used to go about things. And I still admire that about him. I also admired his ability to, look after his family, as Dr. Rohit Shetty mentioned, which is very important in today's times. Many of our youngsters tend to forget where they come from. And believe me, never forget your family. They are everything for you. They keep you grounded. They keep you rooted. So I second that thought. Thank you, Nati, for giving me the opportunity.
And thank you, sir. Should we move on to the next speaker, sir? It's my great pleasure and honor to introduce our next speaker. He's Professor Dr. Jyot S. Mehta. He's going to talk to us about evolving therapies in the management of Fuchs endothelial dystrophies, his research work, and his entire experience over so many years. I think Professor Jyot again needs no introduction, and I've heard him at multiple international and national meetings, and he's well known and well liked by all the faculty. He is the head of the corneal service at SMEC. He's the head of the Tissue Engineering and Cell Therapy Group at Singapore Eye Research Institute. He is named the Professor of Clinical Innovation at SMEC. He has published innumerable, innumerable publications in peer-reviewed journals and multiple book chapters. What was interesting to me was that his research work has also generated 15 patents, which I think is great. Especially for someone who is actually just like a clinician. And his work is focused on corneal transplants, femtolaser, corneal imaging, corneal infections, refractive surgery, corneal genetics, and keratoprosthesis surgery. So I'll just stop sharing my slide, and I request Dr. Jyot Mehta to enlighten us about the endothelial dystrophy.
Thank you, Kavita.
Jyot, congratulations to SNEC for the 30th anniversary too.
And congratulations to everyone at AJE for the 30 years. So reaching the early part of the 30 is the new 20 though, so as 40 is the new 30. So we still have, we're still young at 30 years old. Okay. So I'd like to congratulate everyone at AJE for 30-year anniversary, and congratulations to Dr. Natarajan for a fantastic and inspirational talk. So I'm going to be talking about evolving therapies in the management of Fuchs endothelial dystrophy. These are my disclosures. They don't really pertain. They only pertain probably to the endoglide, which I'll talk about, and some new therapies I'll talk about at the end that are related to trefoil therapeutics pharmacology. So Fuchs endothelial dystrophy is a binatural disease of the corneal endothelium, and it's basically associated with accelerated endothelial cell loss, changes in Descemet's membrane, and the accumulation of extracellular matrix, and focal excrescences that we call basically guttata. And of course, it's described by Professor Ernest Fuchs. This picture is taken over here in 1910. I put this 1910 picture here because this was the year that he described the dystrophy itself. And in fact, he was a well-accomplished anatomist, ophthalmologist, and also mountaineer as well. And he published in numerous numbers of editions of his books, initially, which was finally published in 1945, having had 18 editions and translated into multiple languages. And of course, you'll be familiar with many of other conditions in the eye that are associated and called Fuchs, such as Fuchs heterochromic sarcitis, Fuchs coloboma, Foster-Fuchs spots, and other things as well. And of course, his prime thing referred as a corneal surgeon is his description of Fuchs endothelial corneal dystrophy. But initially, this was described as a dystrophy of the epithelial cells, dystrophica epithelialis of the cornea. And the interesting thing is that this was described in 1910 by Professor Ernest Fuchs. And of course, the slit lamp by Goldstrud really only came in 1911. So if we look at the pathological features of late onset Fuchs, you can see the Descemet's membrane changes into 5 layers from its typical 2 layers over here. So you have the replication of the anterior banded layer, but often you get an attenuated or reduced posterior non-banded layer, but a much thickened posterior banded layer. And this is where the guttae are basically formed. And this is associated with high levels of collagen, typically collagen A. You then have a border layer that forms, which is composed of thin fibrils of collagen with 2 different banding zones, a fibrillar layer, And typically, patients with Fuchs have an overexpression of C1, collagen 1, 3, 4, laminin, extracellular matrix proteins such as clusterin, and also basically proteoglycans. All this work has been done from immunoexpression and proteomic studies. But we have to remember that Fuchs endothelial dystrophy is not just a disease of the endothelium. It is also a disease of the stroma. This nice study done over here, looking at above pictures using in vivo confocal microscopy, showing you mild, moderate, and advanced Fuchs. You can see the endothelial pictures at the bottom, show changes within the stroma in patients who have basically different grades of basically Fuchs. And you get cellular and structural changes not only in the anterior middle stroma, but also basically in the anterior stroma. And now we basically know that these changes occur actually quite early on in the disease, even before the onset of detectable edema. Likewise, we know that basically in more advanced cases, you're going to get epithelial changes where you can get intracellular edema, typically bullae. You may get epithelial basement membrane dystrophies and map lines. And of course, we also know that you can get a denervation in the nerves. And this is due to secondary toxic changes in the nerves. And you can get almost a neuropathic epithelium forming in basically advanced cases. And this may basically be impaired with the epithelial healing. The epidemiology of the disease is two types of disease, early or basically late onset. I think most of us on the panel would think that 40 to 50 is sort of middle age and not really late onset. There's slight female preponderance. Recently, there's a paper by Professor Ula Jakunis's group in America that showed the reason why women have a much more higher propensity of getting Fuchs compared to basically men. And this was due to the estrogen having an effect on the DNA adducts, causing genotoxicity. There is a variation in prevalence. You will see much more cases in the northern hemisphere, typically from Iceland. In this study, almost 11% of basically females over the age of 55 compared to males. In the Japanese study, you only show basically was only 4.1% in patients over the age of 40. So you do see geographic variations, and there are associations to myotonic dystrophy, keratoconus, axial hypermetropia, and also shallow anterior chambers. So the symptoms of Fuchs, I'm sure you're all basically aware of, and typically early on, you can get mild Goutte basically changes that you can see in the retroillumination and the pictures over here. But even these changes can cause forward light scatter. The area of the Goutte have been correlated to causing reduction of visual acuity and contrast and intraocular stray light. And obviously causing this stray light glare can basically affect your visual acuity. And one of the key things that we've learned basically over the more recent years is that you can get these anterior corneal changes with this backscatter even in the early stages of Guttata. And this is preceding detectable edema. The importance of this is when we start to talk about therapy, such as basically endothelial keratopathy, where we're only changing the endothelium, then of course the stroma in the patient is going to basically remain. And this is important because of course we're not going to change the stroma of the patient. So if you want the rehabilitation for the vision to be faster, we may have to think about intervening early before these stromal changes occur. In advanced stages, as you know, we get diurnal variation, and you can basically again get secondary epithelial bullae, like in the retroillumination picture you can see over here. Now, since Goutte play a major role in understanding of the disease process, of course, you can examine the Goutte just simply looking at them on a slit lamp to basically see the presence of Goutte and the basically number of the Goutte as well. But this can be quite tedious, and this is only a 1-by-1 frame. You can take photographs of this and you can manually basically count them. But what is more interesting is actually using automated software to actually see if you can actually count the number of Goutte themselves to give you an idea if patients getting a disease progression or how much the Goutte can have an effect on the vision. And when you do this and as a comparison using some computer software, you're able to basically determine the actual amount of Goutte in comparison to basically manual compared to an automated system. And using this software, we're able to show that even though you did get a slightly higher count with the automated system compared to manual system, you generally got quite good correlation on the bland Alban plots. So that's taken from a 1-by-1 image. But what about if you do the whole eye? So if you do a whole eye over here, you can now get these kind of plots over here when you get a heat map of Goutte deviations, and you're looking to look at size and intergutter basically distribution. And likewise, we're able to show from these pictures over here that using this software that we developed, it's actually quite reproducible with respect to patients coming at different time frames. But that's just basically one patient. What happens if you want to look at 40 patients? Well, with 40 patients, you can even look at 86,000 Goutte, like we've done over here. And typically, you can get basically a zoning map over here. So typically, you can see the highest density of Goutte are in the infratemporal zone, where you can see this yellow basically patch basically appearing. And you can see the radiation out from this area towards the green zone, where you get lower density basically of the Guttata. You can then do things to look at the guttata spacing, where you look at the highest density of this guttata. And previous work that we've done studying endothelial cell migration has basically shown that 40 micron spacing between the guttae is important to allow endothelial basically cells to migrate. And this is important when we talk about regenerative therapy later on in this talk. So when we look at clinical grading now, Kretschmer's grading initially from 1978 was really quite a basic grading system, and it's very good for research, and a lot of people are basically using this over years. And I think if people are doing penetrating keratopathy, then of course this is basically fine. But now we're doing way more advanced surgery, and we know the patients are going to have subclinical edema or changes in the anterior stroma, even though they do not have these 5 continent guttata with stromal or epithelial edema. And we know edema can occur even if you have basically less guttata. So this grading system needs to basically be refined. You can use patient-reported outcomes, and this is quite a useful health questionnaire that's developed by the Mayo Group. But obviously, subjective determination of edema hasn't been really well defined. Some people use ultrasound biochemistry. We know endothelial cell counts are not very good to do in patients with guttata. You can use ASOCT, but this is what I use. It's a paper published by Sanjay Patel in the Mayo Clinic, and he uses shine fluid imaging. And using shine fluid imaging is a very good way of really assessing your subclinical edema. In early cases, you will get a displacement of the thinnest point of the cornea, like you can see in this picture. You get a loss of the parallel isopachs. So isopachs are basically bars of the same pachymetry level in an eye. So you lose the regularity of the isopachs. And typically you'll get a focal protrusion into the anterior chamber. So you can see this depression over here, minus 37. And this is how I follow my patients up in clinic using shine fluid imaging. One of the biggest advancements in Fuchs has been the onset of what we know with genetic diseases. And really the biggest advancement in late onset Fuchs has been the identification of the CTG repeat sequence in TCF4 and intron2 as the main pathological process in the disease. But you'll see from these studies over here, these are the countries in the middle. There is a large variation if you look at the Fuchs column over here with respect to prevalence of CTG expansion. In more Western countries, you'll see this varies from almost 70 to almost 80%. And this is a study from Singapore, from my clinic. Basically, most patients are about 44%. There's a study from here in South India where it's only 34%. So clearly, there is some genetic variation in patients that are diagnosed as having Fuchs, whether it's diagnosed in the United States, in India, or basically in Singapore. And there are other genes that have been associated with Fuchs from other GWAS studies that really need to be elucidated in these multiple sets. This is one of the advantages if you can do genetic testing. So this is from patients from my clinic where we basically tested them to look at their repeat sequence, and 40 is typically taken as your cutoff. So you can see here at 5 years, patients who had less repeats than 40 compared to those who had greater than 40 are showing a high propensity of keratopathy. So we can predict down to 5 years, if we know what your repeat sequence is, what is the chances of you having to undergo corneal transplantation. The other thing I want to show you is over here, however, is that when you get to 10 years, you can see the 2 bars are almost aligning. So what this tells you is that Fuchs is a disease not purely of genetics, but is what we call a complex genetic disorder. And what's the complex part of the genetic disorder? Well, it's UV oxidative stress. So it's UV irradiation. And it's the UV irradiation that pushes you into basically giving you that extra exposure that causes oxidative stress and basically will allow these cells to undergo basically this what we call the vicious cycle of basically of toxic endotheliopathy. What happens is that your oxidative stress will give you cellular dysfunction. This will cause you a toxic environment where you get an aberrant secretion of extracellular matrix. This basically affects your pump function. And this basically cycle continually goes round and round in circles as long as you have that UV stimulus. And that's why you have to think of the disease outside just purely genetics, but also there's going to be an environmental factor as well. So if we look at basically what the indications are for corneal transplantation, Fuchs is really the #1 indication. If you look at the data from EBAA over here in the bar, which is C over here, you'll see overwhelming it is the most common cause for transplantation. On the right-hand side, you'll see data from Singapore Nationalized Center up until 2017, and you'll see Fuchs over here in blue, Bullish keratopathy, which we still see quite a reasonable number of cases that are referred to us over in green, and basically regrafting down in 3 over here itself. And our Fuchs numbers have been going up, and our Bullish keratopathy cases have been coming down. But you'll see there is a difference, shows you between cases that we see in Asia compared to what's reported in the United States. So we've seen an evolution of surgery basically for Fuchs. Since 1905, of course, penetrating keratoplasty was the most dominant procedure. 1998, Garrett Mellis described basically PLK. Then we had basically DSEK, DMEK, and now we have basically regenerative therapy. But really, 1998, when DMEK was, or PLK was first described, was really a landmark year. And some of you may actually think it was almost like an alien intervention that we switched from basically PLK to basically performing from PK. And this has been a massive revolution in the way we go do our surgery. And now we're at the threshold of doing regenerative and cell-based treatments. In the future, we're going to be talking about DNA and RNA therapeutics as well. So what are the differences between PK and basically EK? The key differences are the refractive quality that the EK patients basically get. On the left-hand side over here, you'll see a typical DSEC case. On the right-hand side over here, penetrating keratopathy case. And of course, it's the maintaining the tectonic strength, the lower reduction rate in rejection, and the faster visual rehabilitation. That's what all drove us to basically doing EK surgery over penetrating keratopathy. And this has had a direct, massive impact on the number of surgical procedures or the type of surgical procedures that we do. If you look over here in the red bar, you'll see basically EK and PK over here and ALK down the bottom in green. This is data from EBAA. And you can see over here in the US, EK became the dominant procedure back in 2011. At SNEC, EK became the dominant procedure back in 2008. And you can see over here, it's continually managed to climb, and PK has continued to manage to decline over the last basically decade. So PK has really become the dominant transplantation procedure. But the outcomes are not the same when you look at multiple different data from different countries. On the left-hand side, you'll see data from Singapore Corneal Transplant Database, where you can see the reason why we switched primarily to EK as our first choice procedure is because we have better outcomes compared to what you see on PK. But this is data from the Australian Corneal Graft Registry, where you see the EK outcomes are actually worse than penetrating keratopathy. So it shows you that there is a learning curve effect with these new surgical procedures. The EK procedure or DSEC procedure basically is made up of 5 different parts associated with recipient preparation. Typically, we do this through a scleral kernel. Donor preparations, which is done typically with a microkeratome preparation or cone basically done manually. You strip basically the decimase membrane away. This is done with normally with reverse Sinski hook. The donor is basically then inserted in the eye, and the graft is basically kept in place using a high pressure air tamponade. And typically for our DSEC cases, we'll basically use air to keep the graft into basically position. And this is normally done for at least about 8 minutes, and then we basically release the air from the eye itself. And over the years, it's been shown, this is one of our papers back in 2008, that the biggest cause of damage to the endothelial graft has been basically during graft insertion. So back in 2005, when I was doing basically DSEC, we used to insert the graft using a tacrofold, as you can see on the left-hand side. We then published first time in 2007, the sheets glide, and then of course we developed the endoglide basically in 2010. And this shows an evolution in surgical outcomes, and this has been shown with respect to better outcomes with these newer insertion techniques compared to using basically the tacrofolding. And this is basically shown in this graph as well. However, we do have to bear in mind that in Asia, often we see a lot of cases of bullous keratopathy. And if you compare the outcomes of bullous keratopathy versus Fuchs with respect to visual acuity and also contrast sensitivity, you will see the Fuchs grafts do much better than the bullous keratopathy. And this is important when we're comparing data to the United States, for example, where the majority of the cases are actually Fuchs and there's hardly any cases of bullous keratopathy. Now, over the years, obviously, there's been a greater evolution where we're losing even more stroma. So we've gone from DSEC to ultra-thin DSEC to basically DMEK. And of course, we all know that the problem with DMEK is the difficulty with surgical, difficulty using the thin graft, but it does give you better early visual acuity results and certainly gives you less rejection. And this is typically, you can see from over here, this is 2 of my patients. They have 6/6 vision in both eyes after triple procedure, but it took 12 months to get the vision on the right-hand side. And it took 1 month to get the vision on the left-hand side. And this has been shown in multiple series of publications where one eye has had DMEK and the other eyes had DSEC, and people genuinely see better with their DMEK procedure compared to the DSEC procedure. The other big advantage of doing DMEK, of course, is that you basically the rejection rate is much less compared to what we see with DSEC, but they may be associated with higher rates of rebubbling initially when you're starting with this new procedure. And DMEK itself has evolved over the time. Initially, when I started DMEK back in 2015, I used to use basically an endothelial out procedure where we inject the graft inside the eye. And on the right-hand side, you'll see the new endoglide that was released in 2016, 2017, where we use an endothelial in procedure itself. And it's pulled in with a 27 gauge forceps. And this is the new endoglide that goes through a 3.2 millimeter basically incision. The advantages that we've basically felt from basically using the endoglide to put the graft into position is that it allows you to have more control of the graft, especially which is important in basically more complex eyes. And this shows you the differences between the surgery of using endo out basically versus endo in. And this has had a dramatic effect on basically how we do the surgery. And likewise, if you look at the data from the EBAA at the top, you see the DSEC is really on the decline. And you can see from my own data over here, 2017 was when we really got going with basically the new endoglide. And now DMEC is my primary procedure that I will do for most of my EK cases, and DSEC has really been relegated almost to as low as basically as PK. And the advantage is really for those more complex cases. As an example, a patient that has a previous PK and an ACIOL, doing this using an endo-out technique is very, very difficult to do. But using it with an endo-in technique, when you can pull the graft in with these 27-gauge forceps, allows you to have full control of your DMEC tissue inside the anterior chamber, allows the graft to basically open up, so there's no chance of touching the ACIOL, and then you can simply inject an air bubble inside the eye for the graft to be open up and basically put into position. So I think that even DMEC has basically evolved over the last basically 10 years to make this procedure more reproducible. But the next evolution really has to be in cell therapy. And the reason why that is because despite the fact that everything that I've shown you, you do need good quality donor tissue. And 50% of the world have no access to basically tissue. And this is, of course, compounded by an aging population. And if you look at the distribution of corneal tissue per capita, this is Singapore over here, this is India over here, but there are many countries, almost 50% of the world, have no access at all. And this means that basically only 1 in 70 of the world's needs are basically being met. Now, Fuchs is an interesting disease because there's early disease, which is quite localized, where we can think about a regenerative therapy model, or there's a late disease where you have more widespread endothelial basically cell damage, where we basically would look at basically cell therapy as a model. But the problem with early diseases is that it's not all homogeneous. So if you take this example over here, where you have high density digitata, if you're doing simple DMEC, then it's quite simple. You just simply strip the whole thing away, and then basically you put a graft in. But if you're going to use a regenerative medicine approach, either DSO or basically DMT, how much do you strip? If you don't strip enough, the cells basically won't migrate and the patient will still have catata. If you strip too much, there will basically be a delayed basically recovery. And this goes back to what I showed you with that software, where you're able to look at the catata in basically detail. And what we managed to develop with this software is what we call the enhanced strip zone. So it calculates the maximum area that basically you can strip away the catata to ensure that you're only taking the catata of the highest density. And these are some examples of patients in my clinic that most of us will consider early basically disease, but you can see the difference between the enhanced strip zone for these patients undergoing a regenerative therapy approach compared to undergoing a basically standard DMEC. So this allows us to differentiate our patients into basically even subtypes of basically early diseases. What are the procedures that I'm talking about? Well, basically one is DSO, which is on the left-hand side, and one is DMT, or desmoid membrane transplant, on the right-hand side. The DSO involves stripping away the high density of the catata. This is a video courtesy of Greg Maloney. On the right-hand side over here, you can see a desmoid membrane transplant, where we're going to transplant a pure acellular membrane of desmoid membrane to help basically endothelial cells migrate after it's basically inserted in the eye. So once the catata is stripped on the left-hand side, you'll see that'll be the end of the case. On the right-hand side, the stripping is similar. You have to strip a central 5mm zone, so you can do it slightly bigger than on the left, and simply inject your pure desmoid membrane, which is without any cells, into the area of where the graft has been stripped. And then what we do is we use SF6 gas to basically stick the graft into position. These are some of the outcomes basically from the DSO on the left-hand side. This is our initial series of our DMT cases basically on the right-hand side. And these grafts basically will clear, but you've got to bear in mind, these are all the patient's own cells. So you can't do this basically for most people, but in a certain group of people, this will work actually quite well. Adding in ROCK inhibitors will basically help with the cellular migration, and these two studies basically show that you basically get faster cell recovery if you basically add in a ROCK inhibitor with the treatment compared to no ROCK inhibitor alone. But you can get some side effects of the ROCK inhibitor, such as this honeycomb basically edema. Okay, if you're going to do these regenerative medicine therapies, you have to bear in mind that there is a difference between anatomical closure, physiological function when the cells start to basically function properly, and then pure anatomical polarity when you actually look at the cells over here. What you can see is that even though after the cells will migrate after 5 days of closure, it takes 10 days to get proper physiological function and 28 days to get normal cell circularity. So there is always a delay in basically how these cells will mature, even though you may get full cell contact inhibition. So for late therapy, you basically have to think about cell therapies. And of course, if you're going to basically look at cell therapy, you need to basically expand your endothelial cells to multiple basically cells. And there are 2 IRB approved clinical systems at the moment. Our systems are the one above, and this is a system from Professor Kaneshita in Kyoto, which are both undergoing clinical trials. And using these expansion profiles, you're able to do a 240-fold expansion. So you have one cornea can treat almost 90 patients. Once their cells are expanded, they have to be delivered, and typically this is either using cell injection or using a tissue engineered graft. On the left-hand side, you'll see basically tissue-engineered graft. There's a video at the top and a schematic on the bottom. It's similar to an ultra-thin DSEK, because at the bottom it's being done in a rabbit eye. Once the graft is prepared in the lab, these are engineered grafts, so that's why it's basically yellow at the top. You simply implant them. Typically, we use the endoguide to basically do this. On the right-hand side, you'll see preparation in a patient for cell injection therapy, and at the bottom, done in a rabbit. So typically, you only need to remove the central area in a patient. In a rabbit, we have to remove the whole endothelium. And once the cells are injected inside the eye, then the patient or the rabbit is basically then inverted. The cells will then sink down over the area basically where there's no cells at the moment. And currently we have a clinical approval trial for the left-hand one, and we're waiting basically for the right-hand one once we've sorted out which is the best ROCK inhibitor to basically use. These are some of the results you'll see on the left-hand side. So these are the control in the middle. This is the one with the T and TK graft in the middle, and the one with cell injection at the bottom. And on the right-hand side, you'll see basically the outcome. So the blue line over here shows you the TK graft. In the middle one, you'll basically look at the where the cell injection, and the one at the bottom is where we leave the Descemet's membrane behind, and the one in the gray bar is when we basically remove the Descemet's membrane. And the one at the bottom shows you a comparison between TK and basically cell injection therapy. And of course, this landmark paper by Professor Kinoshita has basically shown this works in patients as well. And he was able to show a 2-year follow-up with some clear corneas in the first 11 patients. But interestingly, if you look at the patients that had Fuchs, you'll see at 6 months post-injection, already you can see some guttata. And these guttata become much, much more prominent when you see them at 24 months post-injection. So maybe for Fuchs, we have to think about removing the guttata as well. So the final frontier is really, this is my last slide now, really showing basically DNA or RNA therapeutics. And this really goes back to what I showed you about the genetics. So we know that the CTG repeat expansion is the main disease profile in a lot of patients, and you get these RNA foci. And using gene or RNA therapeutics to basically inhibit these foci, you can see these foci basically gone in this picture on the right-hand side. And you can use CRISPR and Cas editing to basically delete the sequence from the patient. But you have to remember, as I said, it's a complex genetic disorder, so you have to think about treating the environment as well. So looking at medication that can reduce oxidative stress, either N-acetylcysteine, methylphenic acid, or lithium, have also been used in studies. May have to be done in adjuvant to actually treat the oxidative stress part and not purely the genetics part. But this is an exciting future where we may actually be able to treat patients before they have any clinical features of disease. So in conclusion, endothelial surgery has advanced more in the last 20 years than the previous 90. I'm so glad I did my fellowship within the last 12 years. PK is not the standard for Fuchs anymore. EK is, and really DSEK has been overtaken by DMEK. Despite this, there are many people worldwide who do not have access to tissue, and new therapies allow us to increase the utilization of the current donor pool, and especially this is important during the current COVID situation. Current outcomes for DMEK are outstanding, and further improvements may be incremental. Regenerative and cell-based therapies offer exciting prospects, but still many questions need to be answered. It's really the interaction between the cells and the gluteal cell migration. This is some of the work from my team, where we have this high-power magnification system in our lab, where you can actually cut out the individual guttata and see how they basically interact basically with our corneal endothelial cells. Gene therapy and topical pharmacotherapy, I think, offer the final frontier of treatment, and we can actually, with these approaches, we can actually treat the patients before they have frank clinical disease. I want to congratulate you again and thank you very much for your attention.
Thank you, Dr. Jyot Mehta, for that wonderful and comprehensive talk. While I threw the session open to the panelists, Dr. Ashish Nagpal and Dr. Sushmita Shah, whether they have any questions to Dr. Jyot. I had 2 questions for you in particular. Number one, you said that, the genetics, there is an exogenous influence of UV rays and smoking. So to what extent is it reversible, or is it just something which you have studied, like the effect of it? I mean, is it reversible if the patient stops exposure to UV light and smoking? And my second question is, in the next decade, where do you see the role of regenerative therapies versus the surgical therapies that we are doing currently, like DMEK? Do you think they are going to supersede, the surgical therapies?
Yeah. So, I mean, patients who are smoking, of course, we tell them to stop smoking, right? Because that's something that's easily changeable. UV exposure, of course, you can try UV protection and things, but it's impossible to completely eliminate UV exposure. I mean, I live in the equator, so we have high levels of UV exposure, but certainly we know many UV diseases such as pterygium, cataracts even occur in basically patients with high UV exposure as well. So I think you can certainly counsel your patients to reduce it. The answer is going to be the UV causes oxidative stress. So the answer has to be to find a way, or there are ways in which you can basically reduce the oxidative stress for the individual topically, hopefully with some sort of pharmacotherapy. With respect to your second question about basically where do you see this going? Well, we have 2 countries now where they have clinical trials for cell therapy. I think that more countries will come on board with this. You've got to realize that 10 years ago, there was hardly anybody doing endothelial cell therapy because culturing the cells has been notoriously very, very difficult to do. Now there are about 8 centers around the world using our same technique that we do for basically culturing the cells. So hopefully that will basically carry on itself. The biggest thing that's going to basically prevent widespread use is going to be in countries' individual health authorities with respect to regulation. And it depends on how much that's going to basically be an issue itself. But there's no in question. I mean, I've done cell therapy, cell injection a lot on basically on our animals. It's very simple. I mean, it's a less than a 5-minute procedure compared to doing a DMEC or basically a DSEC. It's simple to basically do itself. The animals basically just will posture basically face down. It's really, really a simple procedure, and it makes the transplant procedure into something that's really could be done by almost a comprehensive ophthalmologist. But whether or not other countries will be able to do it will be dependent on the regulatory authorities. Of course, our first trials cost a lot of money because it's phase 1, basically phase 2 studies that are ongoing now. And it may be a cheaper way of having cell therapy centers that you have one center for half the country or one center for a state that culture the cells and then sends it out to the individual surgeons as well. So that might be another approach of reducing the cost.
Dr. Nagpal and Dr. Sushmita, do you have any questions for Dr. Jyot?
Yeah, Dr. Mehta, excellent presentation. We are now reading about procedures like the DMT and the DSO. So do you think we have enough evidence as yet to incorporate those procedures into our clinical practice? And would you just, for the benefit of the audience, just describe what would be the ideal patient to where we can, or the stage of the disease where we can incorporate a DSO or a DMT procedure?
Yeah,
or possibly the DSO mostly.
So either of those, so they fall under regenerative therapy. So you need somebody who has quite localized disease. So central, basically guttata. You want to be able to scan them with specular microscopy in the peripheral area to look at the endothelial cell count, so they have reasonably healthy endothelium in the periphery, because those are the ones that are going to migrate. What I showed you with the pentacam is very useful, and that paper that I showed you with our software has just come out in AJO, I think about a week ago and stuff. So you can look in there to learn how to calculate the area that basically you need to strip away all that central basically guttata. So those are the kind of cases that you get. So typically I see people often with scarring in the very central area, and if you just do a phaco on those patients, the patients are still going to have visual deficit because they've got a scar there. And instead of doing a full-blown DMEC on them, I like to basically do this because you can just basically do a localized area. You have to always remember that you can always do a DMEC on these patients if it doesn't clear. And I tell most of the patients that normally I'll wait 6 weeks to basically see that it's cleared. We do regular OCTs on these patients every time they come back every week. So I know that basically the cells are basically migrating. My only caveat is that I would basically use a ROCK inhibitor. We use repressor as our ROCK inhibitor. So I do use a ROCK inhibitor now on all the patients basically who are undergoing this kind of therapy, because it certainly will have an effect on how fast the cells will migrate. So I'm not sure I would do it if I didn't have access to basically ROCK inhibitor.
But Dr. Mehta, in India, we have the Repasudil, which is approved for glaucoma, and it's not the Y2763, which is used by both your group as well as Dr. Kinoshita's group.
We don't use Y237. We use repressor, which is made by Aerie. It's used it's FDA approved for the United States for glaucoma. Y237632 is only a lab compound. So the laboratory studies are done using Y237, but we never use it for clinical patients. We use repressor for the clinical patients. But in the US, they're using Repasudil. So if you have it available, then you can use Repasudil.
And for how long and what kind of dosage would you recommend if you want to do it with a DSO?
So you probably want to put it about 3 to 4 times a day. I'll probably use it for about 6 weeks, 6 to 8 weeks. So you can monitor biochemistry using the therapy. The other trick, or the other thing is that, I didn't go obviously into detail on how to do the surgical procedures, but you must be careful that when you do the stripping with DSO or DMT, that you don't dig in to the stroma. You dig into the stroma and you'll get very small nebulae there at the back of the stroma, because basically you're gonna irritate the underlying keratocytes. So when you do the stripping, there are plenty of forceps now that are available. You're better off peeling with a pair of forceps as opposed to do typical stripping like you do basically for standard DMEC or DSEC.
And it's in one of your papers, you've also mentioned that possibly just scraping of the endothelium instead of removing the death bed is also possibly a good modality as far as, which helps in the regeneration of the endothelium.
We do that for children. So it's a procedure called selective endothelial replacement, SER. So we do it for kids, typically with Peters anomaly. So it works very well for Peters. The reason why we don't do that in adults is because adults, they have Guttata, children don't have Guttata, 1. And 2, we know that the endothelial cell migration is much faster in children. So you're relying on the effect of the children's, because they're young, of course, undergoing basically endothelial cell migration. So that's why we basically do that in the kids. So in adults, you can't do that because you need to basically remove the Guttata, because that's the visually significant problem.
Yeah, and another last question, Dr. Mehta. In India, we do have more of pseudophakic bullous keratopathy rather than fugues. Many times these are actually fugues which had been missed, the diagnosis would have been missed. Yeah. Now, in this kind of cases, if they come in the early stage, do you see any role of this DSO with ROCK inhibitor, etc., any role of this kind of modalities instead of EK?
So you'd need to assess the peripheral endothelial cell, because if your peripheral endothelial cells are reasonably healthy, so it shows you there hasn't been widespread damage following the phakic emulsification, and it's mainly central, and that's why they basically got the edema, then you know it's worthwhile, basically you can give it a try. If the peripheral endothelial cells are damaged, then of course the cells that you want to migrate, so with all these procedures, you're relying on the paracentral and peripheral cells to basically migrate. So if they're damaged in any way, it's not possible for the tissue to basically to heal from there itself. So you need to assess the paracentral and peripheral endothelial cell, either with specular microscopy, ideally, or confocal, to give you an idea of what the cell count is. Typically, if it's above 1,000 in the periphery, then the cells should be able to migrate. Yeah.
Thank you.
Okay. I had just one question. Do we have time?
Yes, we can take that question. Meanwhile, I can just share the screen for the next speaker.
It was a fascinating talk, Professor Mehta. I wanted to pick your brains on, we have certain cases of keratoconus along with fuchs, as you mentioned. So I just wanted to pick your brains as to what is your plan of management in these cases? Yeah. Or do you do anything differently for the cross-linking?
So I think that, you can certainly, so it depends if they're progressing. Typically, if they're associated, the ones I've seen where they have fuchs and they have keratoconus are generally older anyway. So the risk of basically progression is actually quite small. It's not like basically in the younger group of your keratoconics. The difficulty arises when you kind of do a triple procedure, because you're then going to have to calculate what your IOL is basically going to be. So in this situation, what I would do, first of all, because your IOL calculation can be quite tricky in this situation, because you've got the edema from the fuchs, especially if they're decompensated, plus you've got the issue with the keratoconus to deal with. If you need to do an endothelial keratopathy procedure, I would just do a DMEC by itself. I wouldn't do the phaco. Okay, so I just do if the cornea is decompensated, just do the DMEC, leave it, then go back and then do a phaco. I wouldn't do a standard triple procedure, because then you can get a better idea on the calculation of your basically keratometry. If you've got if the cone is steep, I've never seen this in a young person. I don't know, Rohit sees a lot of keratoconus, so it'll be interesting to see what he says, but I've never seen it in a young person where you have to basically then do the graft, the endothelial graft first. Right. If you have in a young person, of course, I'd monitor them because of their keratoconus. If they're getting progression, then I'd basically cross-link them. If they basically decompensate, or as long as they basically fulfill the criteria for cross-linking, I wouldn't have any issue basically cross-linking. You would have to warn the patient and tell them, of course, there's a chance they may decompensate, but you could always then do an endothelial graft for them afterwards. I'd just leave them faking and do an endothelial and do a DMEC underneath that if I had to.
All right. Okay. Thank you.
Wonderful. Thank you, Dr. Mehta. Thank you for sharing your vast knowledge and experience with us. We'd now like to move on to our next speaker. Our next speaker is Professor Dr. Rohit Shetty. He's going to talk to us about innovative imaging techniques for the new normal. Dr. Shetty, again, needs no introduction. He is the consultant cornea and refractive surgery and the vice chairman at Narayana Nethralaya, Bangalore. Not only is he a clinician, but he's also a translational scientist at the GROW laboratories at Narayana Nethralaya. He has a PhD and he's faculty at the Department of Ophthalmology at the Maastricht University. He has keen interest in all ectatic disorders, keratoconus, mainly post-LASIK ectasia, and he wrote publications. He is the chief mentor in the dual program.
After understanding all these mechanics, a new era, I have entered a new era. I perfected my technique to the extent of discovering and describing peculiar situation. I I have started adding my own thinking. So one of these new terminology I have introduced in the big bubble, what I call it the tricky big bubble, or the collapsing big bubble. You see here, you inject air, and then you will have the big bubble, and it will collapses while you are going out. You see soft tension. If you are do it in slow motion, you see this is the edge of the bubble, quite clear. And when you are going out, it collapses through a leaking. You see the collapse through a leaking track. And you go and you do the small bubble test, it is negative. So this kind of collapsing big bubbles, I think I am the first one to describe such a phenomenon. At the peak of my experience, I was so brave and confident to start doing phacoemulsification through DUA's layer, what we call the triple phaco DUA, the triple phaco DALC, sorry. So this is a case of phaco through the DUA's layer. So after having the big bubble, type 1, you do lamellar dissection, and you open the big bubble, you remove the stromal flaps, and you will notice now the tough surface of the DUA layer, and you will start doing your phaco through this tough layer. As you know, the DUA layer is very tough, making your phaco incisions as usual, and making the dermatorexes and the capsulorexes and nucleus rotation and hydration. You can do whatever you want through this tough layer. You are doing nucleus fracture and rotation and chopping through this tough DUA layer, because I know that this is type 1 bubble with a very tough surface. Now you are working through a 15 micron layer, and even you can implant your IOL and finish your operation safely. The road was bumpy, full of ups and downs. However, I gained quite a reputation and recognized internationally, and become an invited guest speaker in many esteemed meetings and societies, as you see from this slide. As you see, I have found myself among the stars of lamellar surgery all over the world. Professor Tan, Professor Dua, Professor Sarnicola, Professor Fogla, Professor Goel, Professor Sadir Hanoush, Mark Terry. And I have won too many prizes in appreciation of my humble and unique work. This was my story from zero to hero, my 13-year big bubble journey. And I hope that we can meet again some other time to share with you another tough journey with this delicate demacrol. And thank you very much for your kind attention. Thank you.
Thank you so much, Dr. Katamish. That was wonderful. I mean, I think all the DALC surgeons who have learned, who are aspiring DALC surgeons, would have definitely learned a lot of tips from your talk. I throw the session open to the panelists, Dr. Nagpal, Dr. Sushmita, if you all have any questions. I just had one question in that peculiar case in which you showed, and you had a double bubble where you punctured earlier and then you went back and punctured, the DUAs. So I'm just wondering, like, what if we had just left the second bubble in place? Do you think it would have mattered?
Why I didn't lift the second bubble in place?
Yeah. If you could have, just done like a pre.
Because the second bubble was so huge and very large, and it will take some time to go away, and it will make the closure of the wound very difficult. And I can leave the second bubble, but this could be done if I have a small partial big bubble type 2. But if I have two big bubbles, I think it is very difficult to leave it in place.
Great. Thank you so much.
Good. Can I ask a question?
So can you stop
Yes,
sharing your screen, sir?
Yeah.
Okay. I am stop sharing. Pause share.
Okay. Professor Tariq, that was a superb talk as usual. We really enjoyed
your videos and such basics. It's really wonderful. So I'm going to ask you two basic questions. One is, what has been your experience to use Helon or any visco expressive device for getting the big bubbles?
Actually, I'm aware of these visco bubbles, but unfortunately, I have no experience. I find my way quite easy and quite good with using the air. So actually, I didn't have any experience with doing visco bubbles.
Okay. And my second question is just to ask you for some tips on how do you get such a well-centered trephination in the keratoconus patients? Because a lot of times I see it kind of shifts when after you put the vacuum in my hands. So what tips would you give?
This is a very important question. I take some time of doing this step, and I have a lot of eccentric trephination at the my early course. My tip is to fix the caliper at a certain distance, for example, 4.5 millimeter, and to make a mark from the nasal limbus and then temporal limbus and then superior and inferior. And inside this box, you are in the center. And I have to check first by putting the trephined edge and center it over this before doing my actual trephination, and I have to check that it is centered before cutting. And if my calculations are okay and the preliminary mark is centered, I go for final trephination.
Okay, so that is why you make that box to see which we could see in the videos. Yeah. Okay.
I make the box by making any way of centration you can choose, whether using a caliper or using a trephin over the cornea, but you have to be sure before actual trephination that you are centered over the cornea.
Okay.
Thank you, sir. So if you could just stop sharing your screen, sir.
I have a question, Dr. Katamish. Excellent videos, very, very informative and very, very nice. Regarding the big bubble injection, in your videos, you are typically not going to the center of the cornea. You're always a couple of millimeters away. That is, there are some surgeons who recommend that you should take your cannula up to the apex of the cornea and inject. So, how far do you think the cannula should be? Because you have demonstrated excellent type 1 bubbles with the techniques and the tips that you have recommended to us today. So how far away should the cannula tip be from the apex of the cone, from the center of the cornea?
I think, in my opinion, it is not the center of the cornea, which is important. I think what is important, as I have mentioned, is to be very deep. So there is no need to go to the center. And some cases you know that it's very thin center. So there is no value to go to the center. The main value is to be as deep as you can. So I usually do it in a paracentral location. And I know that other surgeons are doing this in somewhat peripheral locations. So in my mind, the depth of injection is much, much more important than being central or paracentral.
Thank you.
Thank you, Dr. Tariq.
Thank you, Kavita, for this opportunity, and I would like to thank all the speakers and panelists for this great opportunity to be with you this day.
So can I request you to stop sharing the screen, sir?
For me?
Yes, sir.
Okay.
You have to stop sharing your screen. Yes, thank you, sir. Thank you so much.
Thank you.
I request Dr. Jaideep to welcome and introduce our next speaker.
Thank you, Dr. Kavita. So it's a great pleasure to introduce Dr. Gavin Tan from Singapore Nationalized Center. And he's one of the senior Retina consultant at the Singapore Nationalized Center. He's also a visiting consultant at the Retinal Service at Shanghai General Hospital. He is also a very excellent cataract surgeon besides a vitreoretinal surgeon, and he is actively involved in academic and research and leads multiple clinical trials at the Singapore Eye Research Institute. So Dr. Tan is also the director at the SNEC Ocular Reading Center, which is one of the major imaging centers for diabetic retinopathy and retina related clinical trials in Singapore. He is involved in the development and implementation of a national diabetic retinopathy telemedicine screening program and is studying the use of novel approaches, including OCT, automated detection of retinopathy. Next slide. In addition to many of his academic achievements, his special interests are also in artificial intelligence and innovations in the field of vitreoretina. So I welcome Dr. Tan to give his talk on innovations in retina and artificial intelligence.
Hi, thank you very much for the kind introduction, and congratulations to Dr. Natarajan and to your eye center. It's very nice to see that both our center and yours have gone through 30 years of development. So let me just share my slide. Okay, so good. So everybody, so we're moving on here to the eye. Topic is the involving.
Dr. Tan, you're not audible. Can you speak a little louder? Like, speak up a bit.
Hi, is that a bit better?
Yes, sir. It's better.
Yes,
Sorry about that.
Dr. John from US has just joined. Welcome, Dr. John. Thank you, Gavin, and hearty congratulations to SNEC also for the 30th anniversary. I know the physical meeting has been postponed to next year.
Yeah.
I hope to join you.
Yes,
welcome.
You'll be able to attend next year. So I'm going to talk about artificial intelligence and teleophthalmology innovations in retina. So these are my financial disclosure. So what is artificial intelligence? It's a branch of science that looks at creating intelligent machines. And the principle really lies in machine learning, where you try to create an algorithm that develops mathematical models in order to make decisions, classify data, or make predictions based on the information that you provide the machine to learn on. And what's really happened is we've gone from classical machine learning to deep learning, where because of increased computing power, the machine is able to increase their performance closer and closer to a human with the increasing amount of data and training that we can provide it. So the main thing about deep learning and retinal imaging is we tend to use a convolutional neural network. And the key process is identifying unique features or structures of images, all based on the patient's data, and it builds a statistical model to determine the probability of an outcome. It still requires supervision. It's just like you training your trainee. You need to train the computer by providing it with as accurately phenotyped or characterized data as possible. And of course, the more data, the better. It's like with any training, the more cases they see, the better they become at doing it. So this is an example of the most common form of screening that's being done around the world, diabetic eye disease. And you put it through an algorithm that breaks down the images into multiple layers. And based on the features it then identifies by itself on the layer, it develops a probability model that determines if this image is healthy or diseased based on the training that it has undergone. So the components in developing artificial intelligence or machine learning models for healthcare are quite reproducible, or it works as any other scientific process. You need to identify the problem. You need to have a specific question that you're trying to ask. In most of our cases, it's whether an image has a particular diagnosis or not, or whether a patient has a chance of having a particular outcome or not. You need to curate as much data as possible, and then you can put that curated data into the computer system, and then you need to test your algorithm, validate it, and ensure that the algorithm is identifying the correct features that you would expect, and then put them through clinical trials to ensure that they are really effective in a real-life situation. So the first example I'm going to talk about is diabetes. It's a big problem around the world. And screening, we know, is really, really important in order to prevent blindness from this disease. I think Google produced or published the first deep learning algorithm for diabetic retinopathy, where they showed a very good sensitivity and specificity for identifying referable diabetic eye disease. In our own experience over the years, we also developed a similar deep learning system for diabetic retinopathy screening. And in our system, we had hundreds, a total of 500,000 images, some used for training and a lot of others used for testing and validation in order to develop our own algorithm. Again, this was done using a convolutional neural network where we labeled all our images depending on the presence of diabetic retinopathy and macular edema, and we put it through a GPU-based learning system, and we allowed the computer algorithm to identify its own important features and develop its own convolutional neural network to identify which disease was present. And of course, once we developed the algorithm, we had to test it against our retinal specialist, and it proved to have very good sensitivity and specificity, both for referable diabetic retinopathy, and more importantly, it seemed to have a very highly reproducible and very sensitive ability to pick up vision-threatening retinopathy compared to our non-physician human graders, which was the standard of care at that time. We also validated the software in different ethnic groups and situations, and that's very important because it's just like any other algorithm that you work out or any other test that you develop. If it only works well in one population, it's not going to be translatable or reproducible, or it will have very little clinical value. And beyond that, we also tried to do a visualization. So this is a very important step when you talk about deep learning or artificial intelligence for imaging. You really want to know that the machine is identifying the exact same components that you would have done so as a human being, because that will validate that it is performing the right way. In this case, in this patient with that macular edema and retinopathy, we see the machine is able to identify the new vessels, the probability score being highlighted in green where it thinks the disease is, as well as the hard exudates at the center of the macula. The same process allowed us to develop a deep learning system algorithm to identify glaucoma suspects, depending on the disappearance, as well as the presence of intermediate or worse age-related macular degeneration. So once we had our algorithm, we want to test it and apply it. In Singapore, we have a diabetic retinopathy teleophthalmology program. Like many of the programs in India and Singapore around the world, you usually have an image capturing site. You transmit data to a reading center. Most places right now use humans to read those images, and you send a report back so action can be taken. In order to implement this in our system, we already had an existing screening system. We had to ensure that the IT platform was in place to allow integration. We developed the software. It was spun off in order to get regulatory approval, and it was put into the system with a long-term prospective clinical trial in order to assess the efficacy. So in our efficacy trial, we wanted to look at not just replacing human, but really looking at cost effectiveness of this whole system. Since this is not a situation where it is a population that is naive to diabetic retinopathy screening, we already had a screening system, we already had a human-enabled system, and we need to prove it was better than our standard of care, or at least equivalent. So we wanted to compare what happens if we use the algorithm to replace our human graders altogether, or the alternative is we use the algorithm as a first pass and still use humans in order to provide arbitration or improve the effectiveness of the screening, with a comparative assessment based on clinical and cost effectiveness. So we had two components. We initially studied it with comparison with a retinal specialist grading, which provided some form of gold standard, and subsequently compared the AI versus our current standard of care, which was not a retina specialist arbitrating all the images. Again, the results were quite similar to what we showed earlier, which validated our system worked as well in the lab as it did in real life. We had good sensitivity and specificity for the AI, and it was particularly sensitive for detecting vision-threatening diabetic retinopathy. When we compared it with our standard of care, what we found was that the AI alone seemed to have slightly poorer specificity than a human-based model, However, when we compacted the model and used human to arbitrate the suspicious images, we were able to improve the overall specificity of the system. And that proved to actually be the most cost-effective model because referrals to an ophthalmologist in our context were expensive, both for the patients and our healthcare system. So taking that beyond just diabetic retinopathy screening, we've tried to use these same fundus photos to detect other diseases. And we have found that using these photos of these diabetic patients, we are also able to predict if they have chronic kidney disease. And that you may ask, why do that? Because laboratory results are always available. That might not always be the case in non-developed countries, where it may not be as easily able to test a patient's creatinine clearance, whereas in the future, with smaller and smaller handheld devices, you could have an iPhone-based screening, which you could take out to community and screen for both diabetic retinopathy and kidney disease at the same time. We have also used the data available to us to look at deep learning to assess the vascular features and changes that we find on these retinal images and correlated them with the cardiovascular status. And we found that different components of cardiovascular risk factors did correlate well with the measurements that we could train a deep learning software to make on the retinal vessels. My other colleagues have also looked at identifying papilledema and disc swelling from fundus photos. And if you can imagine right now, they are not always available ophthalmologists to examine the eyes in these patients who may have papilledema in the emergency department setting or the neurosurgery setting, and this may be a potential use for them to allow a machine to help them identify these cases without referring to ophthalmologists. Other groups within our centers also looked at deep learning to try and predict if the visual impairment from a fundus photograph and to predict what may be the possible cause of the visual impairment. So a lot of times you can develop more information from the photos than your human can assess or predict just based on our recognition. We have also tried to expand the use to more common diseases because at the end of the day, if your learning software can only identify diabetic disease, it's never going to replace a human. A human is expected to examine and determine among the hundreds and thousands of diseases or diagnoses available, which one is there. So we have to slowly take that step in the machine learning training. So we really haven't got to the ability to replace the human's full diagnostic capability in terms of diversity, although for specific tasks, it's getting better and better, maybe equivalent or even better than the human's ability to do those diagnostic tasks. We have also taken the step to look at other modalities like OCT, where we've tried to identify macular edema. Other groups have also done this, and they have taken the step to expand the possible diagnosis that the machine can identify. And in this effort by Google, they have an OCT software that can identify over 50 different disease outcomes from an OCT. Beyond just diagnostics, the next key area would be clinical decision-making, and various groups have tried to segment OCTs in order to help identify when patients need injections or not, or even better, will the software be able to tell us if the outcome is going to be good? At the moment, these software is good at identification of treatment indications, but they haven't reached the level of sophistication that would allow us to then predict outcomes with a great deal of confidence. So there's still many challenges in using artificial intelligence in ophthalmology and retina management. We still have quite limited access to well-curated prospective data sets. There's still some lack of real-world evaluation. A lot of the papers that you read do a lot of evaluation in the lab, and the real-world performance can be quite different. We know it's difficult to explain the black box and how the AI makes the decision, and it's very important to elucidate that, because if not, you end up with bias that you will not be able to appreciate. And of course, you do need the infrastructure and IT platforms that will allow these algorithms to be implemented in your clinical system. And at the end of the day, although they're getting better and better, they still do not replicate the complexity of a human's multifactorial decision-making process. Although with more effort, we should be able to get there someday in the future. The second part of my talk is going to talk a little bit more about teleophthalmology and other innovations in retina. and how all of us have to think about adapting to maybe it's a new normal post-COVID, and the fact that a constant threat of emerging infectious diseases. So telemedicine or telehealth is the means of providing healthcare remotely with telecommunication tools. It can be provided synchronously or asynchronously, and how the interaction occurs could be dependent on video conferencing, telephone calls, imaging devices like we do with screening. And artificial intelligence is a key enabler in this whole process. So telehealth has really been put in the spotlight again with COVID-19 because it's an opportunity. Patients can't come to us. We're not allowed to open our clinics because of lockdowns. And so we need to adapt to figure out where this will be technology will be able to help our practice of medicine and ensure it doesn't result in the decades of disappointment and unmet expectations that people have experienced with technology. So with telehealth and AI, we feel there will be synergistic and complementary digital technologies that will improve the way we do our healthcare, and the emerging ability to do big data analysis, faster 5G networks, security with the blockchain will enable these processes to be implemented at a high. We already see increased adoption of telemedicine in the Asia Pacific because of this disease. In our own experience, there are a range of telemedicine or teleophthalmology models that we've tried to implement, from video consultation to imaging clinics to home monitoring. And in Retina, we've tried to do things like having virtual clinics where we do all the imaging at community sites or at fast turnover sites, so patients don't have to dwell in the ophthalmology clinic. They can be reviewed by technicians or eventually by AI in the future. And decisions can be made remotely, and management can be made by the doctor based on those imaging. And it's as needed, video calls or teleconferences can be set up with the patient to communicate these to the patient. In addition, I think the use of technology for home monitoring and self-vision assessment is more and more important. It could be home vision apps that allow us to assess visual acuity or other parameters at home, to other more sophisticated home monitoring apps that are more sensitive to changes in retina performance and function. Our own experience with a teleophthalmology home monitoring system, which uses vernier hyperacuity to detect fine changes in retina function, has been quite has shown us that this can be a very useful component in allowing us to reduce the monitoring or the follow-up burden for our patients. This is an example of a patient who would have been visiting us regularly for injections, for treat and extend, or PRN regime. What happened in COVID is we could not see them for regular mundane follow-up visits. And so we gave him the app to follow up his own visual function. And the app score did identify the drop in his functional vision. And we called him back, I think it was 4 months after the last injection, because of the drop in the score. And we noticed the peripheral cystoid macular edema has recurred in the central zone, causing the drop in the app score. And interestingly, his visual acuity uncorrected, or his presenting visual acuity didn't drop between these two visits. But because these technologies try to replicate what you do in an Amsler chart, which is to assess not just the central visual acuity or function, but the functional drop or distortion that occurs in the peripheral vision, it is able to pick up these diseases more easily. And we think in the future, retina medicine is going to be home monitoring, remote acquisition, AI helping you make disease diagnosis and prediction of risk, and physicians directing treatment, which may be on-site or even remotely implemented. So in conclusion, digital technology will really transform retina and eye care. Teleophthalmology and AI are highly connected, synergistic technology platforms that will enable this to occur. In retina, artificial intelligence is proving to be increasingly good at doing specific tasks with good real-world evidence to support its use. But really what we need are multi-diagnostic or multifunctional algorithms, and these are quickly upcoming and being developed. And these future algorithms can help provide further insight into disease progression, prediction, as well as the relationship of ocular findings and systemic disease. And I think the new normal that we have in COVID will provide even more unique opportunities to apply these innovations into our daily practice. And with that, I would like to acknowledge all the people that have worked with us on all these projects. And I would like to thank the organizers of this meeting for allowing me to speak. Thank you very much.
Thank you, Dr. Tan, for this wonderful talk. I now request Dr. Jaideep to open the session for discussion with all the senior retina surgeons on panel, Dr. Natarajan, Dr. Preetham, Dr. Swapnesh, Dr. Karobi. Please give your inputs.
Thank you, Gavin, for a wonderful talk. And my interest also is on AI. So yesterday I gave a talk to a local engineering college. We're working with them. We're also working with a company in Bangalore called Remedios. We worked on offline and AI and published in JAMA. And now Dr. Jaideep is working on with the Forest for delivering home care, retina care at the home. So I'm actually interested in your app, and I hope Jaideep, me, and all of us can work with you, and whether we can share the app with us for our patients. I don't know, whatever needs to be done, we can work together. And with
So congratulations. I know your group and many groups in India have been very, very successful. I mean, India has always been the forefront of implementing teleophthalmology in eye care. And yes, we will be very happy to see how we can work with you in these future collaborations to see how this care can be delivered.
Probably keep in touch with you, because now I think the new NEA director is also working on AI.
That's correct. Michael has been
in ROP, and Dr. Jaideep works on ROP, and Dr. Keratopathy also in ROP. So we want to do something on AI, and I'm also in touch with Dr. Tin Wong and Daniel Ting, and we have some MOU, and we have some publication with Charumati on the process with your colleague, and hope to work together more and contribute to the science. Jaideep.
Dr. Karobi, Dr. Preetham.
Yeah, I have some questions. That was a wonderful presentation. Can you hear me?
Yes.
Yeah, so that was a fantastic presentation on teleophthalmology and artificial intelligence. In fact, I've spent some time collaborating with a company in the UK, the Visualitics, which also has come up with some teleophthalmology and AI platforms. And one of the concerns I believe in these fields is the variability in the various machines which capture the images, and then sending images from different machines and different platforms to a common software which will read the images. So that is a stepping block, I'm sure, in these technologies. So how do you? I mean, what is seen? How can that be ironed out?
So I think for retina funders, photographs is a bit more straightforward because most of the cameras have quite similar field of view and magnification. What we've found is for fixed retina photographs, once you train it, it works well irrespective of most of the camera types. However, the interesting thing is we find the handhelds though have a slightly different performance, and you do need to do additional training for handheld cameras because the field of view tends to be a little bit smaller. The quality of images tend to be a bit less. So the difficulty then goes to when you transit from just simple two-dimensional images to OCTs. And I think that's a challenge that everybody still has as a work in progress. There have been a lot of groups that have talked about how transfer learning is able to then let you train on one OCT device and still have successful results on another device. But in real life, none of these softwares with using transfer learning have actually gone to market yet, because in our experience, it is challenging. And I think maybe there needs to be more standards that the ophthalmology community needs to advocate for. So what we found is, compared to our radiology colleagues, the way resolution of DICOM images are put out is a lot more variable and proprietary in ophthalmology compared to radiology. So that has been a stumbling block. So I think the various ophthalmology societies may need to nudge these companies to make the data a bit more open source so that these device-specific limitations can be overcome.
Jaideep, can I ask one question?
Yes, Swapnesh.
Swapnesh, please.
Yeah. Dr. Gavin, I wanted to ask a pointed question since you have done so much of work on artificial intelligence in retina. What are the medico-legal implications of a misdiagnosis on AI platform? That is one. Second is, how do you handle patient privacy, the data privacy, which is shared on these various platforms? And third thing is, because diabetes is not only a central but a peripheral disease also, are you moving into the direction of wide field fundus photography and maybe Octa, which may be more of a wishful thinking? So those are my questions.
So those are very, very pertinent questions and things that everybody is being challenged by at the moment. So I think medical legally, you need to firstly get regulatory clearance so that you're doing something that is an intended use. And then you need to be able to provide a regular, so our regulatory agency requires us to provide regular audit. We do know there will be missed cases. And I think the company that provides this system will need to work with the doctors to figure out what the legal implications are. Definitely, the company, just like if you do a lab test, the company does have some liability, but the person ordering it also will need to take some responsibility for the fact that after a test is ordered, they need to verify the outcome and so on and so forth. So it is a very important question. And I think companies are trying to work out, I think, similar to malpractice insurance to protect themselves. For data security, it's very important to ensure that. I think America and Europe has a lot of data standards, whether it's the HIPAA standard or the European Data Protection Standard, which ensures that companies that provide these health services encrypt their data in the appropriate manner. In Singapore, we do have very strict standards as well. And I think it's important for us to comply with these standards, and we shouldn't be sending unencrypted email with this patient data across platforms. And the last thing is, yes, diabetes is not just a central disease. I think a lot of groups have been trying to look at how wide field imaging will affect the interpretation and management of the disease. But we also have to balance with the fact that while a tertiary center will have access to this, the real benefit you will really provide for the millions of diabetics in the populations if you can send this technology out. And real wide field technology is not ready for that kind of use yet. But that being said, what we have found is that AI is able to pick up subtle changes sometimes in the posterior images that can predict what you would find in the periphery. And maybe the AI will, by training AI using the raw or the ground truth from wide field images, you can develop a software that can predict peripheral changes that you don't will not be able to see with 45-degree fundus screening. So I think there's a lot of future development that still needs to be done and future work that still needs to be done for wider implementation.
Dr. Gavin, I had a question for you.
Yeah.
I had a question for you. That was a very nice talk, and you have just opened up a new vista in front of all of us, because this is something which is going to be our future. I had a small question that they have different forms of artificial intelligence where a specific artificial intelligence is where it surpasses what the human brain can do. So is there any field of ophthalmology where you feel that the artificial intelligence is able to give us information which we are not able to, as clinicians, make out? And the second is, will this artificial intelligence or the super intelligence which is there wipe out or make the doctors redundant in any way in the future?
So I think the biggest benefit is that the machines can pick up trends, patterns, biomarkers that we find it hard to do with the naked eye. And I think it's very evident in imaging technologies. I think Dr. Shetty mentioned it as well in about how AI can be used to develop to analyze corneal topography. Humans need very obvious features. You need to, if we see fluid, we just tell if it's a large amount of SRF, maybe we can tell it's IRF. Whereas if you train the machine with enough outcomes, it will start to pick up tiny little patterns of change that we can never pick up the human eye that may be able to predict some outcome better than us. So that's where I feel will be very strong. But I don't ever think, at least maybe not in my lifetime, that the machines will ever replace us, because it's still not artificial intelligence is still not really intelligent. It's just building more and more complex models to replace what we do as humans. And I think at the end of the day, medicine is an art. So you cannot replace the art of medicine. You still can't replace a lot of things, from decision making to the ability to do complex surgery. I don't think robots will be able to handle those fine tasks in a long time to come. So we will still have our role. Whether our children or grandchildren will be replaced is another question altogether. And I think that's too far in the future for me to speculate.
I think well said, Gavin. I think that's right, because whenever I give a talk on AI, the people are worried whether it will replace doctors. But I'm sure, I think every problem or every app or every new technology in AI is a man is behind it, and it's not the AI is doing on its own. I don't think ever it will happen, and it should never happen also. I think we should have the control. And I'm looking forward to work with you, Gavin, not only for publication, to do something together, because we have only 77 million diabetics in India. And I don't know how many million ROP KL will tell. I think we need non-medical people to do the screening and retina people to do the treatment. So I think even then we have only 1,000 retina specialists in our Vitreoretinal Society of India for a 1.3 billion population. So we need, I know Singapore, like being a small country, but your contribution to the world science on AI in ophthalmology is amazing. So we wish we will work together.
Yes, look forward to that. Thank you again for inviting me to speak.
John, do you have any comment? John? Maybe. Okay, so that Jaideep, you can.
Thank you.
Okay, I'm so sorry. So this is John Prakash. Good morning. Yeah, thank you. I think it's very timely that we actually put together a bigger consortium, but I can actually talk about it, address it more, in a detail in my talk. So this is really the time is here now, and we should really move forward with a global effort. Thank you.
So we have Singapore, we have NIH, and now next, I think, Jaideep, you can start the next part. We are a little delayed, John. Sorry for that. We are over enthusiastically discussing.
Thank you, sir. I think we'll move forward from here. Thank you, Dr. Tan, for the wonderful talk. And I request Dr. Akshay to introduce our next speaker, Dr. Gangadhar Sundar.
Thanks, Jaideep. Dr. Gangadhar Sundar is one of those people in oculoplasty who fulfills the cliche, he needs no introduction. But I'll still go ahead anyways. Dr. Gangadhar is the head and senior consultant of the Orbit Oculofacial Surgery Unit, along with ocular oncology at the National University Hospital, Singapore. He obtained his medical training from Madras Medical College. He's one of the few practicing surgeons who went in from India, was American board certified, is also specialized in oculoplastic surgery from the Henry Ford Hospital in Detroit, where he obtained his fellowship. Most of his academic achievements are enlisted there. But what I will tell you is that he's one of the few people who always has been ushering the younger generation, people who've just finished their fellowship, his own fellows, whether it's in terms of being involved with organizations like the AP Sopris, the Asia Pacific Ophthalmic Trauma Society, or the AO Foundation, whether it is asking them to take part in the organization, the logistics, or mentoring them and presenting them. He's always been at the forefront, and I've been lucky enough to be at the receiving end of this. He's forever looking to educate. And I think the biggest tribute that Indian oculoplastics has is that the best paper award that is awarded to the paper that is presented at the annual Oculoplasty Association of India conference is called the Gangadhar Sundar Award. Again, I was lucky to receive the award from his hands in 2018, and he's not stopped following up with me on whether that paper that I presented has actually been submitted as a manuscript or not. Such is his interest in making sure that anybody who presents something sees it through till completion. And he's going to be presenting us his wisdom, his experience, and his pearls as an oculofacial trauma surgeon over the past 20 years. Professor Gangadhar Sundar.
Thank you, Akshay. I come in between just to say that we both share the same birthday. So September 4, and plus his father was my teacher. He was later the professor of, he was the principal of Madras Dental College, which is a part of Madras Medical College. And he's from the same alma mater, both Madras Medical College, my postgraduate, Shankaranethralaya, everywhere. And Gangadhar is, I learned from him a lot every time. Thank you, Ganga, for joining us.
Thank you, Mr. Natarajan. I hope my mic is on.
Yes, we can hear you, sir.
Yes, you are. Yeah.
Thank you for your kind words, and more importantly, thanks a lot, Akshay and Dr. Kavita, for your kind invitation to join you all in this wonderful evening. It's my pleasure to join you and felicitate the entire Aditya Jyot family. I know there's been a past with a lot of people who have been working with Aditya Jyot in the past and continue to work with him. And I know Aditya Jyot is not just a physical building that you see in Dadar. Actually, it extends all around the world in physical capacity and mental capacity. And I'm one of those people who've been inspired by the man behind it, Dr. Natarajan. So I'll be touching a little bit about my journey, my stories on orbit and orbitofacial fractures. And I'd like to share my limited experience and bring you greetings from various society. And the society I mentioned in the top is one of Dr. Natarajan's legitimate children, which was conceived a long time ago, which I'll touch upon it later, and has grown to a wonderful society in itself. So greetings, not just Aditya Jyot, but Singapore National Eye Center and St. Erik's in Stockholm, Sweden. And I wish one day I will visit Stockholm, Sweden to attend the Nobel Prize receiving ceremony, either for George Mehta or Dr. Rohit Shetty, Dr. Natarajan, or hopefully one of my oculoplastic surgeons whom I'm very familiar with. Professor Natarajan, as you all know, is a man, is like a hamster on a wheel. He's constantly going around from place to place, getting things done, moving people along. The few words that Akshay mentioned about me, I'm whipping him actually to push and deliver more. And he has been contributing immensely. Likewise, Dr. Natarajan has been immensely inspiring people, not just in Mumbai, not just in India, not just in Asia Pacific, but all around the world. And the baby I am talking about was the Asia Pacific Ophthalmic Trauma Society 2004, which has conceived a long incubation period and finally delivered officially in 2011. And actually is probably one of the most active trauma societies. So much so that our Ophthalmic Trauma Society has been inspirational for the American Society and has formed the American Society of Ophthalmic Trauma. So due credit to Dr. Natarajan, Dr. Azad. If there's one thing or a couple of things that I've learned from Dr. Natarajan, it is these two. Don't take no for an answer. And he's a classic example of that, where no matter how many brick walls he faces against, he either jumps over them, breaks around them, or somehow gets the vision that he achieves the vision that he has. And also taught me the power of positive thinking. Move away from people who have negative thoughts, who always keep saying no to what you try to do, and give the power of positive thinking. And that has actually facilitated me and inspired me over the years. So what I'm going to touch upon in the next, say, 10, 15 minutes is going to touch about my personal journey on orbit and oculofacial fractures, some conceptual approaches, some newer advances, and what is there in the future, sharing with you my journey, some stories, and innovation. Some disclosures: I serve as a faculty for AOCMF Foundation globally and regionally. Some publications, yes, there is some trauma-related publications without any conflicts of interest. So my journey was in Chennai, like Dr. Natarajan mentioned, with the Madras Medical College, probably one of the oldest medical colleges in India, and subsequently trained under the Regional Institute of Ophthalmology, Government Ophthalmic Hospital in Chennai. And so these are several common things that I have with Professor Natarajan. But after that, when I wanted to pursue ophthalmology, instead of going to the UK, which is what majority of people did, I went on to America, which is where really I got my solid foundation basics, which I still drive into my fellows so many years later. And since my return, I joined Shankaranethralaya, which was an immense experience because dealing with personalities like Dr. Bhadrina, Dr. Gopal, Dr. Surendran, who have inspired me for several years. And I knew them before, I knew them then, I know them now. They have really been the mentors of sorts for several people around India, and subsequently joined the National University Hospital of Singapore, which is now a National University Health System, which is a 2,000-bedded complex of multiple hospitals with various levels of training. And that's where I've learned a lot from where I'm speaking from. I'd like to give credit to my teachers, both in Chennai and Henry Ford Hospital, Detroit. But what I do, sometimes importantly try to teach my residents is that your greatest teachers are your patients, not just where you have the successful outcomes, but where you have less than suboptimal outcomes. And when patients sometimes are silent, they don't give you verbal cues, but you have to pick and learn, critically look at their outcomes, and they are the ones who actually goad you to do more, and which is what the journey I'm going to share with you today. So our university hospital is over 33 years old. It's got more than 2,239 beds in our own hospital. Within our system, more than 1,500 beds. We are one of the very few hospitals in Singapore which is affiliated with a full-fledged medical school and a dental school. We offer both adult and pediatric services and do complex work as well. And till date, we have managed a lot of these, and it's the mistakes that we have learned, like Dr. Natarajan was talking about earlier on, from whom we have learned, which is what has really propelled us to start forming new ground and continue to keep doing better for our patients. It is important to recognize the team that you work with, and this journey to me is very important because these are the people who have made me what I am today. Dr. Shanta and Dr. Stephanie, who used to be working with us before, and more importantly, I'd like to acknowledge our OT nurses. If not for them putting up with all the nonsense I put up in the operating theater, and they're the ones who encourage us to keep delivering more. And apart from that team itself, the picture down below shows the neurosurgeons, the plastic surgeons, the rhinologists. They are the ones who actually showed me, opened up new frontiers for me, which is what I am today. So I'm going to touch a little bit about newer anatomical concepts beyond the standard postgraduate textbooks, some imaging considerations, where we have made new contributions in the field of orbital anatomy and orbital pathology and reconstruction, some newer innovative implants, and finally a little bit on future. So when we as ophthalmologists look at the human eyes, the way Dr. Natarajan sees it is the fundus behind, or Dr. Rohit Shetty or Dr. Jyot Mehta sees is the topography or the multiple layers of the cornea itself. But as oculoplastic surgeons, when we look at a patient like this in the front, what we're really looking for is actually the deeper inside the orbital socket itself, the various soft tissues within the orbit, and finally and most importantly, the structure, the functional structure and the aesthetic structure is the globe itself. And that's very important for us to see conceptually, because when you're reconstructing faces and orbits, that's what you're reconstructing and putting it back together. Traditional description of orbital anatomy is a floor, medial wall. We used to be taught that all orbits are the same, which is not true at all. So sometimes textbooks lie. If you look at the top picture, shows the floor of the orbit, which is a nice convexity towards the maxillary sinus. That's not the way orbital anatomy is. So we have now revisited the orbital anatomy and conceptually thinking about it as a picture frame where the four superior, inferior, medial, lateral rims are present. And deep inside the picture frame is the four walls of the orbit, which is what we need to reconstruct. And we're going to touch about some anatomical landmarks, including the orbital strut, the posterior ledge, all of which was not known to us about 15, 20 years ago, and the various sutures. And finally, the terminology that we introduced into orbital anatomy is the angle of inframedial orbital strut, AIOS. Serendipitously happens to be the All India Ophthalmic Society as well. So we now know the floor of the orbit is not just a curve or a straight sheet. It is a gentle S curve with a posterior medial bulge, which if you don't address is why you have post-traumatic enophthalmus when you just put a sheet implant or inadequately reconstruct that S bulge itself. So managing the bulge intraoperatively is very important. You also have to be aware of the orbital strut, which is nothing but the junction of the floor and the medial wall that you see over here. And that is one of the internal buttresses, the strong points of the orbit. If that is busted, the entire globe sinks, not just inferiorly, but inframedially. And if you don't reconstruct it, you're going to have globe dystopias as a complication, even though you think you placed the implant in the right place. Another important part is this anatomy called the posterior ledge. It's a ledge on which the implant sits, and oftentimes we as surgeons, even nowadays, fail in our duty to place the implant on the ledge. Implant ends up on the maxillary sinus. You get limitation of movements and also postoperative enophthalmus. And finally, this concept of the angle of inframedial orbital strut. That's the angle that forms between the medial wall and the floor, and that varies from anterior to posterior. And we have now devised ways of customizing our orbital implants for every patient so that they get a patient-specific implant for these complex fractures. Here's a depiction of the anterior angle, middle angle, and the posterior angle, which varies from patient to patient. And measuring this preoperatively in these patients, unusual patients where they have combined floor and medial wall fractures, and failing to address that is what results in complications. And the application of this is not just in fracture, as you can see in this picture, we have reconstructed the orbit on the left side compared to the right side with the angles, but also in thyroid eye disease, where these angles are obtunded due to chronic deformation from orbital pressure in thyroid eye disease. And we introduced the concept of not just AIOS, but also the angle of medial wall, which is altered in thyroid eye disease. And we have devised now techniques to pre-bend these implants when you reconstruct these orbits. The next important thing is to realize that the orbit, which is an important part of the fit face, is only a part of the orbitofacial skeleton. And oftentimes our residents, when they vomit out the bones that form the orbit, rattle out all the bones, but oftentimes forget the palatine bone, which forms a posterior ledge in the posterior part of the apex orbit. And they don't realize that it's one of the most important bones that forms a posterior ledge against which is placed. So we have to realize that the orbit is part of the facial skeleton with the frontal sinus, the maxillary sinus, lower face, so on and so forth. So when you have complex fractures, you have to see the orbit in association with rest of the facial skeleton. And this is a nice picture of a skull from Mexico that we went, which is used for All Saints Day, I think. But if you have a blown up view of the skull, you have to know that it's not sufficient to know the 7 bones that form the orbit, but you actually know every single bone in the calvarial skeleton up to the mandible. Because if you don't get your frontal sinus right, if you don't get your zygoma right, you're not going to get your internal orbital anatomy right. So quick thing about imaging of the orbitofacial skeleton, we have moved away from X-rays to CT scan. It is not just any old CT scan. Nowadays, we get CT scans with image guidance control. These are sub-millimeter, 0.6 millimeter cuts that we take in the axial protocol with a gantry at 0 degrees, which is then reconstructed and reformatted in the coronal plane, in the sagittal plane, can even be used for 3D reconstruction. We'll talk about its value in navigation surgery. Typical teaching shows that MRI is useless for orbital bones, but we now have shown that with black bone MRI, you can actually visualize thicker bones and can be utilized in certain situations and reconstruct bony orbit with MRI itself. So where you used to order CT orbits, we used to do that. We now have to look at the CT orbits and the face, and you can show that in addition to the orbital fractures, you get maxillary fractures, sometimes even mandibular fractures, which have to be addressed at the same time you're fixing these orbital fractures. So when you move from pure orbital fractures to the rest of the face, most ophthalmologists and oculoplastic surgeons were quite confused. It's a pure blowout fracture. Yes, they're fairly comfortable fixing it, but when it becomes part of the facial skeleton, they're completely lost and they don't even know what their role is. That's why we came up with the practical classification of orbitofacial fractures, which classified them into the traditional simple fractures, which is a linear fracture, blowout fractures, which interestingly account for only 25% of all the orbital fractures, and the rare blown fractures. The vast majority of orbital fractures or orbitofacial fractures, which include the CMCs, the various forms of NOEs, which are very challenging to manage, the Lafort fractures, which involve the midface and the orbit, the cranio-orbital fractures, and finally the panfacial fractures. Interestingly enough, if you look at indications of intervention, yes, the blowout fractures become a far higher component of orbital fractures which have to be fixed compared to the complex fractures. But it's important to have this conceptual idea that orbit is part of the midface is part of the craniofacial skeleton, and do not treat the orbits in isolation. On top of which we defined the patient modifiers, and we gave it a simple A, B, C, D, E, F, G, H, where the age, the laterality, the complexity of the fracture, the degree of displacement, whether the muscles are entrapped or not, whether there's associated intraorbital foreign body, whether it's underlying globe or optic nerve injury, and the patient has a high risk factor, medical factor or not, all defines the threshold for intervention. This combination of both the practical classification and the modifiers has completely transformed the way even my residents can now go through it and decide whether this fracture needs a repair or not, without really looking at the senior consultant or the professor of craniomaxillofacial surgery to decide indications for intervention, timing of intervention, nature of intervention, anesthesia, staging, so on and so forth. So here's an example of a simple fracture on the figure left and a complex fracture with the roof and the floor are involved. Examples are NOE fractures, which traditionally were left to the craniomaxillofacial surgeon, but you have to realize that most NOE fractures have a significant lacrimal involvement. So you want to address the lacrimal component before they put all the hardwares on the face. And finally, panfacial or cranioorbital fractures because you have no idea where to start and where to finish. And you have to have a logistic approach of starting superior to inferior, lateral to medial, from stable to unstable areas with implants. So yes, like a lot of the corneal work, the talks that were given, there has been an evolution of a journey in our orbital reconstruction, and where we have moved away from large incision to small, minimally invasive incisions. We started using navigation technology. I'll touch a little bit about it. And now we're talking about customizing implants, and that's a way to go for complex fractures. So what are we talking about in terms of implants? Traditional implants were actually about permanent implants, and we used to think that when an orbital bone is disrupted, you need to reconstruct the walls and the implants have to stay for life. And more or less that's true for large complex defects. But we have made a lot of contributions in the past 15 years about bioresorbable implants, very similar to technology elsewhere inside the eye and outside the eye. So these are examples of permanent implants that we used to use, moved away from sheet implants to anatomically correct implants, which have appropriate bulges and curves, reconstructing the strut and the floor in the medial wall. And we have used the goniometer, which is an instrument used by orthopedic and hand surgeon, adapted it to ophthalmology, where by measuring the AIOS, we're able to pre-bend these implants when you put it in place. Then there are composite permanent implants. And as you start doing more and more work, as we all surgeons go through a learning curve, we make mistakes. We think we are placing the implant on the posterior ledge, as you can see on the image right, but you realize it's way up there, impinge against the inferior rectus and the optic nerve, causing motility disorders and even in extreme situations, visual loss. Or you can see implants like these which are placed in the sinus. That's why we adopted navigation technology, and we've been using this in NUH for over 15 years now. And navigation technology is very similar to the GPS system. If the cornea anterior segment surgeons are saying that we are using the Callisto technique for the past several years, and that's the same technology we've been using for 15 years. So in a way, orbital surgeons have been well ahead of times, because accurately placing implants, accurately dissecting vital areas in the orbit is very, very important. And this has reduced a lot of complications in complex fractures. And these are various navigational technology systems which uses a IGS protocol, CT scan images I talked about before, 0.6 millimeter scans of the orbitofacial skeleton, which guide us intraoperatively real time to place where we want, so that through smaller incisions, we're actually able to reconstruct these orbits more accurately, as you can see in this picture over here. Whether you see the images in the axial view, in the coronal view, or the sagittal view, you can see the ankle is reconstructed well, the medial wall is reconstructed well, the floor is reconstructed to the gentle S bulge, and the implant places on the posterior ledge of the implant. And this kind of technology can now be used for even more complex fractures, where you can see the entire left side of the face has been disrupted, medial wall, the nose, lateral wall, the midface, where with the same technology of using the right implant with navigation technology, we put it all back together so the patient can go back to leading a normal life. Another important thing that we started realizing over time was, do bones really heal? Do we really need permanent implants? And we showed that you don't really need to. So we have been using a lot of these bioresorbable implants, as you can see in this image on the top, who's got an orbital floor fracture, as you can see on the coronal images, where a year and a half out after reconstruction of bioresorbable implants, these implants are completely absorbed, the bone is completely healed, and the patient does not have to deal with long-term complications from implants itself. And that kind of lends us towards what is the newest advantages, patient-specific implants, which we now use for complex fractures and revision fractures. Here's a lady who, quote unquote, believe it or not, has had a fracture repaired. And you can see on the image over here, there's an implant placed. This is what I call as OIF, open and internal fixation without reduction of the contents. At the same time, she was not very keen on going through very fancy, extensive revision osteotomies and complex reconstruction. So using the IGS protocol, the 3D DICOM data we have, based on the volume deficit or the volume enlargement we have calculated the volume and size of an implant, 3D printed it, and then placed it in place so that we are able to reconstruct it without doing any bony work, releasing the soft tissues and customizing an implant for these patients. So what's really new in the realm of orbit and orbitofacial surgery? Virtual reality. We had a nice talk about telemedicine and artificial intelligence. We are now coming to the foray where there's now augmented reality assisted surgeries, which coupled with which coupled with the 5G technology which is coming, the whole world is fighting over it. We are now able to superimpose a 3D image, the DICOM image, whether it's CT scan or MRI, real time onto the patient when you're operating on them, so that you can actually go see what's on the other side of the tumor, what's on the other side of the bone, with the scan being superimposed to the skull, so that you can minimize intraoperative trauma. So this is going to be useful probably in the next 5, 10, 15 years. You're going to hear more about it. It's not just a teaching tool, but it's going to be a surgical tool as well. So in summary, what I've touched upon are newer concepts in the journey that I've had in orbit and oculofacial surgery, concepts in anatomy for the resident, the fellow, and the practicing orbital surgeon, some new technologies which is evolving. And I gave a talk about 8 or 10 years ago on the future and fantasy of ophthalmology. And believe it or not, I talked about VR and AR then, and that's become reality now. So don't stop dreaming, the younger generation. Just think about it. By the time you're thinking about it, somebody's already working on it. And by the time you finish your training and you're in your mid-career, that technology has become reality. But all said and done, when you have mentors and textbooks and examinations, what they teach you is science. But what I believe is this SAP of ophthalmology. Science is what you memorize and teach and learn. But beyond that, I think this morning, Mr. Bowman Irani was talking about Dr. Natarajan's approach to patients. There's an art in dealing with patients. And that is where you don't treat it as a right eyeball or the left eyeball or the cornea or so on and so forth. It's an eyeball which happens to be, by the way, in the face of a patient. And the face belongs to a human being, and the human being belongs to the family and society. The art of medicine is very important. Finally, there are variations why some people do what they do and some people don't do what they do, the philosophy. So I'm a strong believer that science, art, and philosophy has to be learned, and we need mentors like some of the panelists and Dr. Natarajan, who's actually invited us today. So a quick closing slide from Dr. Akshay Nayar, who has created this for our 5th webinar for the Asia Pacific Ophthalmic Trauma Society. I would dare say it's one of the legal childs of Dr. Natarajan. Do join us for this conference. Thank you very much again for your kind attention.
Thank you so much, Dr. Gangadhar Sundar. I think I can say that I understood a lot of the talk, but I definitely understood your reference of you using Callisto 15 years back. So over to Dr. Akshay and Dr. Rupali and the rest of the panel for the question.
Thank you, Dr. Gangadhar. It was really...
Panel, Akshay, before you start the
Yes,
panel, there is a dream project between you, Gangadhar Sundar, and Arun Singh of creating Aditya or whatever name, eye cancer hospital. And I have tried arranging sponsor, and I'm still, as I told in the morning, I'm again failed in between. But I'm not forgetting the project. Akshay, you are the base of the project, and Gangadhar and Arun will be the honorary directors. So I'm not going to pay them.
Happy to work with you on that, Dr. Natarajan.
Yeah, I know that.
Right, sir. That was really fascinating. Each time I see any of your presentations, there is so much more to learn. I was interested in knowing very often, while operating orbital fractures, especially posterior fractures at the apex, visualization is sometimes an issue. Once you've placed the implant, you don't know whether it's exactly there or not. So what role does intraoperative imaging have? And is there like an intraop? We know a C-arm can be used, but how sensitive or useful is the information that we get from that?
Right, great question. The posterior ledge was actually unknown to us when we did our residency days. And as we started putting these implants inside, we conveniently did not image our patients. And in fact, we did not want to know the implant was in the wrong place. A lot of oculoplastic surgeons by default don't image it. It's people like you who want to really confirm it's there or not, do the imaging and realize, oops, it's in the wrong place. So there are 3 ways of confirming intraoperatively. Number 1, you can use your naked eye. So you need larger incisions. So you start off with larger incisions, visualize it, put the implant in, go back and visualize again. But smaller incisions, that's going to be very difficult. The second thing you can do is using an endoscopy. You can put an endoscope in the orbit or inside the maxillary sinus and confirm the same thing. So you have real-time intraoperative confirmation. That's where the 3rd technology comes in, which is navigation technology. And not all of us have navigation technology, but most trauma centers seem to be acquiring it. Actually, you can do that. What you're alluding to is intraoperative imaging. And instead of the C-arm, better than the C-arm, there's now an O-arm. We have just acquired one now, where after you put all your plates and screws and you think you've done it all right, You do your arm right on the table. It acquires images in about 2 to 3 minutes. And in the operating theater itself, you can literally see the position of the globe, the muscles, and the implant before you close up. And that has become actually one of the standards and is coming in as well. So talk to your orthopedic surgeons. They are the ones who invested in the O-arms. And yes, that has a role.
Right. Rupali?
Hi, Dr. Gangadhar. How are you?
Nice to see you.
Hi.
And you smile. And you smile.
Thank you. Before I ask you a question, the concept of the eye just not being the eye but being in the body and the face and then the body was kind of introduced to me by you when I attended NUH for a small kind of a workshop that you had organized. It was an orbital facial maxillary team which helped us to do these complex fractures. I think this was 2006 if I'm not mistaken. And prior to that in the fellowship, it's just the eye, it's just the eyelid, it's just the lacrimal, etc. And it was then that we realized, okay, if we actually work along with an ENT or a maxillofacial surgeon or a plastic surgeon, the results tend to be much better. The maximum that you can do in the first shot that you can help in the patient will give you the best possible results. From that to now navigation, it's like a giant leap. And now this new thing of AIOS, the angle, the enteromedial angle, that's something very interesting. Now I'm going to obviously ask you on that next time I get a patient with an enteromedial obstruction. So for me, the big question that I want to ask you is, how safe would it be to put such big implants in a seeing eye when you are going to do an inferomedial placement of that implant all the way behind? And what would the approach be? Would you take a conjunctival approach or would you have to open the skin for this?
So in terms of safety, you're talking to in an audience where you have people like Dr. Natarajan and other retinal surgeons who are peeling this microns thin membrane of the retina. And what we're dealing with is not microns thin, it's millimeters thick tissue as well inside the orbit, if not centimeters inside the orbit itself. So yes, the answer is very safe, provided you know what you're doing, you know the patient's anatomy. And I always believe that complex surgeries, when you start doing for the first time, end up with larger incisions. So we end up doing a formal canthotomy, cantholysis, and transconjunctival approach. And historically, and I mentioned this in the book, we used to detach the inferior oblique muscle, then connect it to the transcaruncular or retrocuruncular incision. So you have a single large conjunctival incision of the medial orbit, inferior orbit, detachment to the inferior oblique. And you literally see that space where you're putting this implant inside. But the problem is, even when you put your periosteum back, the inferior oblique dysfunction takes time to recover. And you get a torsional diplopia, which adds to the downtime. So we then evolved to pure inferior transconjunctival incisions and pure medial transconjunctival incision. So you have to reduce the content with a pre-bent implant to the angle that we talked about. We stick the implant along the floor, rotate it around the medial orbit, go to the medial transconjunctival incision, verify the position of the implant, verify the position of the floor against the posterior ledge. Post-suction, you get out. But nowadays, with the pre-bending, you can get away with the transconjunctival incision medially, get away with the inferior oblique disc insertion. You can just dissect the entire medial wall all through the inferior approach like you do for a decompression, stick the same implant inside, and you can do it very safely and effectively. So the answer is yes, it can be done. There's a learning curve, there's a mindset. Sometimes we surgeons are stuck with mindsets. And when you start doing the initial cases, do the postoperative imaging to make sure you have delivered what you wanted to deliver. And then your learning curve is very steep and then you get the plateau there.
Oh, thank you. And these implants are not to be fixed onto the inferior orbital rim with screws? We need to do that. We know you need to.
But if you're using a bioresorbable implant, you don't need to. You close a periosteum over it. So I use a bioresorbable implant for patients who are not likely to be falling down and getting injured again. But men being men who get into fights and brawls and stuff like that, those are the titanium implants that I use, and I anchor it to the inferior orbital rim on the inside of the orbit, not on the outside as is traditionally taught.
Okay. Thank you.
Thank you so much, Professor Ganga.
Thank you.
Thank you very much again for the opportunity.
Dr. Kavita?
Thank you, Dr. Gangadhar. Dr. Kavita, can you put up the slide for Dr. Gyan.
By the time we are putting a Gyan's slide, I just want to tell Gyan has become, John Prakash has become a grandfather today. He's got a granddaughter. And so congratulations.
Congratulations.
Thank you. Thank you. Thank you very much. Thank you.
Dr. Kavita, can you change the slide? I would like to welcome Dr. Gyan, John Prakash, and I think Dr. Natarajan would be able to tell us better about him, but just a few things which I would like to share with you is currently he's leading the international programs and global health initiatives at the Office of Director of the National Institutes of Health at the Nationalized Institute in the USA. And before this, he was Director of Transformational Medical Technology Initiative. And before joining the US government, he was the Chief Operating Officer and Executive Vice President at AMAR International, a life science program management company. So he's done his postdoctoral training in medical biotechnology from UCLA School of Medicine at the center. I would like to request Professor John Gyan Prakash to give his talk.
So John is more than a brother, and professionally he's an international director in the NIH, and he's one of the one who motivates me to continue in research in spite of, he taught me one lesson, how Alexander looked at India, and that's what I keep telling myself every day, that why are we cooking our own food? Why not we have a common cooking so that we can work together? That's what is the idea. I told Kavita, I just dropped one idea and Kavita did the entire program. Thanks, Kavita, for this, because this is what we want. We want multiple, and we are now representing Aditya Jyot from clinical care, patient care to now to research. Thank you, John. You're always part of us, and thanks, and we will get more inspired by your talk to do more research.
Thank you very much. Can you hear me?
John, yes, we can hear you very well.
Okay, very good. So first of all, good morning from Washington, D.C. What you see in the background here is that I represent the National Institute of Health. And National Eye Institute, as most of you know, is part of this larger organization called NIH, which is really the premier research and development powerhouse, which sets essentially, a global mission to conduct research. And before I begin, I really want to congratulate the entire Aditya Jyoti family, Dr. Natarajan, Dr. Kavita Rao, Dr. Jaydeep, for organizing. And as all of you know, Dr. Natarajan is not only part of my very professional circle, but he's also family. And we just had a very exciting last 12 hours, having blessed with our first grandchild. So I feel a little, I'm a little sleepy here, but essentially it's the energy that I get from Dr. Natarajan pretty much daily or every other day that he keeps inspiring in spite of being about 8,000 miles away from us. So congratulations to all of you for achieving the journey. I told him as soon as our granddaughter arrived, I told him that we'll always remember the anniversary date for the Aditya Jyoti Foundation and the institution that he has founded and led, because it will always coincide with the birthday of our granddaughter. So beginning with that, let's see if I can move the slide. So I have a little bigger approach here, and several times I've noticed that it's very, very difficult to follow the energy of Dr. Ganga from Singapore. He's essentially another very power bunny who keeps going, and between Dr. Natarajan and Dr. Ganga, these two people are really one of the most active people that I have ever met in my life. So every time I see them in some part of the world, I try to follow them at least to get my energy going. So I'm delighted that Dr. Ganga just inspired all of us with the fantastic work. He, amazes me, the kind of work that he's progressing and he's doing. So thank you, Ganga, for doing that. So as you can see that, not only that you have the two very bright examples here who keep going around the world, but in a real sense, if you look at any kind of collaboration is essentially very crucial for scientific progress. On your left, you see here that there was a publication several years ago, but essentially this represents that there is a decrease in percentage of exclusive domestic papers. So although this data represents the US, but essentially it applies all over the world, that in the last many years, we have seen a substantial increase in total annual output that includes international collaboration. And technically speaking, the citation impact is typically greater when the research groups collaborate, and benefit and strengthens when co-authorship is international. So international collaboration, doesn't matter how you look at it, any way possible, is a very strong positive influence in both on the journal placement, citation performance in most disciplines, not just in ophthalmology or biomedical science, but all across the scientific discipline. So this is not only the future, but it's here. And we see this every day, even in the time of the virtual presence. So just to give you a quick footprint of the National Eye Institute, the organization that I represent, we are not only one of the largest, or the largest research body that represents the globe, international work. This was our footprint just about 5 years ago, as you can see, and then now going into 2016, and then 2017, and then 2018. And this data I received just last night from one of Dr. Natarajan's friend, Michael Cheatham, who has worked in India and led the Indo-US Science Foundation. So clearly, for National Eye Institute, this data represents that our international footprint has grown tremendously. This graph basically tells you that 2014, we had only about 32 projects, programs in 13 countries, and now we stand in just past 6 years, 381 projects, programs around the world in terms of collaboration, international collaboration, expanding into 45 countries. So you can actually see right here in just past 5 years what has happened. And this clearly has had not only on the impact of our progress, but impact of overall ophthalmic research and science. So the way we view our international research is global science is truly interconnected. We're involved in global research. We always seek scientific opportunities, identify shared priorities, supporting unique international opportunities around the world. We support the U.S. grantee, being the U.S. organization. We support the U.S. domestic grantees to expand their international collaborations. And this is by what? By forming partnership among scientists, governments, companies, NGOs, and all across. You can imagine that National Eye Institute at this point, this year, has over $824 million of budget just for this year, and that expands into over 2,000 research grants and programs. 85% of that $824 million that goes into funding extramural research, which is like providing grants to not only to the US grantees, but as I always like to highlight here, that anyone from any country around the world can apply for NIH NEI grant. And this is a link here that one you can obtain from the NIH more detail. Okay, so some of the examples of international program.
Hi, how are you?
India has always been a very, very active collaborator.
I'm still in the.
And your government is has done a parallel funded program with us, which is about a dozen-year old and has generated into many, many programs. And Dr. Natarajan has all the details. And in the absence of the time here, I'm just providing you some of the quick snapshot of international program activities. So India is a very, very active collaborator with many of the US grantees, and important programs have been developed, and some of the highlights that have come from not only from Arvind and Shankar Nethralaya and Shraf Eye Hospital in Delhi, and and LV Prasad in Hyderabad, but many of your leading institutions have developed program. Here we also have a similar program with China, Brazil. We provide a number of international genomics fellowships, short-term fellowship, long-term fellowships. We just started, and several of the Indian scientists have been trained, clinicians have been trained under this program during my tenure, and they've received the worldwide acclaim. We recently started a collaboration with ICO, and this is a one-year clinical program that many of you would be interested in. I wanted, and you can go on NEI website to get the detail. I want to highlight here that Dr. Ganga was talking about the organization that Dr. Natarajan has helped to start. And one of the things that he has done with us is that he's been an integral part of starting an NEI initiate program called Global Eye Genetics Consortium, and he's one of the key and the founding member with me sitting at the card table. We both were in Colombo, Sri Lanka, and this whole program was born there in Sri Lanka when we were at the SARC meeting, along with the third stooges, Dr. Takeshi Iwata from Japan. So the three of us, we actually cooked this whole thing, and Dr. Natarajan has been serving as the Secretary General worldwide for this organization, which expands into 34 countries at this point. So in addition to this, we have programs with the UK intramural program. We have a number of postdoctoral training fellowship to all nationals around the world, which has been going on for the last 50 years. And people from around the world have been trained, and they have returned back to their countries. Some of the things that you see here, that US-China program, this is the US-Indo program. You have the ICMR Director General with NIH Director signing the program with Indian Health Attaché here in Washington, D.C. This was this is the ICO Fellowship, which was recently signed. And of course, you can see Dr. Natarajan here as being integral part of this worldwide effort. So this was a program with this is Sarpeng Kao from Moorfield Hospital. So clearly there are a number of programs that we have that I can highlight. Once again, you see here collaborative science is done together. You see our acting director, Dr. Santa Timinia here. She is a great supporter and very enthusiastic supporter of all worldwide collaboration. And of course, you see our energizer bunny here, Dr. Natarajan, who is always present and always supportive no matter what we do. This is the very last time we met, the Global Eye Genetics Consortium in Vancouver. So this has all resulted into a number of, now we just finished the third volume, which Dr. Natarajan also served as a helping editor. And you'd all be delighted that we just launched volume 4 of the Springer Nature publication, which is an effort of over 200 members from about 30 plus countries. And this is a global worldwide effort, really generating and bringing people together on anything and everything related to eye genetics. So overall, and this is right here is Professor Neeru Gupta, the current acting ICO president. And this is the past ICO president, along with past director of National Eye Institute. And this is the signing ceremony that, as you can see, that many of the people that you can recognize, Professor T.P. Das, you see here,
Kumar.
Yeah, and Dr. Takeshi Wara and Dr. Kumar Manikavel and Professor Ningli Wang, who is the president of many organizations in China. So this is, and Dr. Sundareshan here, and this is Dr. G.N. Rao. So you can see that this has a very worldwide support, and this is expected to grow and provide the bigger benefits to the entire world community in terms of not only the basic research, but also clinical research. I just wanted to put down some information for you. These are the select funding opportunities from NIH for all international scientists that you would all be able to take benefit. There are a number of resources that one can actually tap into. It's too numerous to actually mention in just one slide, but this gives you a snapshot, and it just, you can look into various areas of research, including the National Eye Institute funding. And additional, there are many other things that are going on. You can imagine that under the current worldwide scenario, we have a huge responsibility working on not only the diagnostics, therapeutics, but also leading the vaccine effort for COVID-19. And we are involved in pretty much in everything that what you see on the television these days. Dr. Tony Fauci, who is right next to the leading the White House COVID-19 task force, is really the leader of this entire effort, and that involves multiple institutes within the NIH. And I also listed here several of the NIH efforts that can keep you up to date on things that we do and can benefit any international scientist. So in terms of final thoughts, as you can see, collaboration is a hallmark of science and research. We simply cannot make progress without it. And not only just in ophthalmology, but across disciplines, across institutions, across borders. As Dr. Natarajan said, that when my father, I grew up in India in a remote village, but my father used to tell me a story that when Alexander came to India and he was on the bank of Indus River on the other side, several centuries ago, and he asked his chief of staff that in the night that, why does he see all this, so many fires burning on the other side of Indus River? And his chief of staff, chief of army said that, sir, because they are cooking. So he said, why are they cooking at 1,000 places? Well, they are all cooking their own food. So I think that story had quite an impact on me, and I keep repeating that if we cook it all together, obviously, we make faster and bigger and better progress. So clearly, if we want to combat the global blindness and prevention of eye on a global level, we need to think about things at global level. However, things can start at the very, very ground level. Many of these things that we just heard from Dr. Tan in Singapore and Dr. Ganga, of course, in his unit, in his clinic, and those things need to happen, and we all need to come together frequently and connect with each other easily, and we work, and we all know that as ophthalmologists, as eye researchers, we work very well collaboratively, and several of the glaring examples are sitting right in this esteemed audience. So we should be making the best use of our science and research excellence, as well as each one of us. So we have unique things to offer, unique population to represent, and answers will come from working at the ground level from unique patient population. And you, believe me, you have several very unique populations in India, in Singapore, in Egypt, and the organizers of this program who are participating in this. And that's where the research answers will come. And this will help us tackle the global blindness and will deliver benefits to the entire world, not only just to your community, but the entire world. So I want to thank you very much for listening to me, and want to congratulate not only Dr. Natarajan, but the entire Aditya Jyot family. I've been to your institution several times, and it's always a very proud moment when I get there, when I go there, and you all have our full support and continued interest. And we want to thank you for your support to the National Eye Institute and NIH. So I'm open for any question at this point. And Dr. Kavita and Dr. Jaideep, you both have done an excellent job in organizing this. So thank you for including me in your program.
Thank you.
Dr. Natarajan, do you have any questions for him and anybody else on the panel?
I just wanted to thank John, and I don't have words to thank. And in a way, I don't have to thank my brother and brother-in-law. My wife is my sister, and I attended all the family functions, and I'm part of Washington. So he always tells you have a second home. And he's got a second home, which is really great. I think when he's inviting me, the entire Aditya Jyot family is invited. He's got a 5-acre property, so everybody can be accommodated, and it's a 4-floor home. And I'm inviting. But more than that, I think more important is every time to tell you whenever I feel low, and because I get bogged down by not able to do whatever research I want, he will tell, no, you are doing great. So I think it is like it's really a great inspiration, and I hope whatever links he has put, I'm sure he's already sent his PPT. We have it with us. So you can, all of you can work in your own field, like oculoplasty. I can see Dr. Shushmita, very eager from the beginning to now. She's there. Thank you, Shushmita. And you saw Dr. George talking about genetics and eye, and we are part of that genetics on keratoconus. Even though I keep telling the Australia team, don't put my name. Somehow they are all want my name. But anyway, Kavita is the main one force working on keratoconus and genetic research in our team. She heads it. One Shruti is their optometrist. So we want to do, there's a global RO1 grant is possible, and nobody can influence. It's only by pure merit, which I learned, which I think we have to know how to write it, and we are struggling with a great difficulty even to submit an application. I think we are having a weekly meeting with Case Western University with our research team, Siddhita, Rajkumar, Dr. Adhika, Asta Jain. They are doing similar thing. I want now Jaideep to work with Kevin Tan. And Ganga is already ready, ever ready to support our ocular oncology and oculoplasty. And cornea, Kavita, I think you should take it. You should probably write a matching grant, which is a Indo-US grant, which is possible, but you have to study it in detail. You need a collaborator in US, and there are multiple PIs possible. You can be the PI here. You can have multiple PI in India also. It goes in hundreds of pages, the application form. So that means you have to spend hours together daily, which is possible. And I'm sure you can do it, Kavita. So today, as I said, one idea I gave and you did the program. I'm proud of it. Same thing. I think you should do a grant. Maybe I'm struggling 3 years. I couldn't do it. Maybe you can do it. And Shushmita probably can join, and you can have a multi-institutional grant. Because we don't have to write only Aditya Jyot grant. That's why even ocular oncology, when I use the word Aditya Jyot, eye cancer, I swallowed. Like America, I learned that my own words. That I don't know. It can be anything. It can be just I want an eye cancer hospital, which is not there in India, only for eye cancer. That means it's not only retinoblastoma. So many ophthalmic cancers are there, which we need treatment, we need research, and everywhere genetics is the base. I'm glad John literally pushed me as a clinician, even though everybody is a non-clinician in that group. I'm the only clinician working with them, but I'm happy because that's how I became a friend of Takeshi. I visited Takeshi lab. So I got a goal that I want a lab like Tokyo National Institute of Sense Organ. It looked like a small kid asking, I want the moon from the mother. So John is the brother, I'm telling you, the brother. But I'm telling that because we have to work for it. We follow Bhagavad Gita. So I hope we will establish a fantastic lab. And already Rajkumar did his fellowship, and Dr. John Prakash gave the first in my parents' name, Dr. N. S. Sundaram, Kamala Sundaram Memorial lecture. That time my father was alive. So that's the first public lecture, endowment lecture, which Dr. John was kind enough to give. And we had a NEI international director giving it. And he's a great support. And I think we have to be proud of this accomplishment. And he feels whatever Aditya Jyot achieves, he wants us to work together. Shroff Charity is there. The hospital in Chitrakoot. And then all are ready to cooperate. And I wish we take this opportunity as a 30 years. I think it is like Arun Gulani gave the talk that I was in the basement of the ship and all of you are in the deck. Now I am in the deck and all of you are in the basement. And Boman Irani mentioned that we have to go down to the basement and then go to the top floor to work. So I think I did that. Now I think it's your turn, Kavita. You can take it as a 0 year and start working. And you too, off to you and Jaideep, Kavita.
Thank all the panelists and all the speakers and taken out their valuable time with us to celebrate our 30th anniversary, and heartfelt gratitude to all of you and who have contributed to this session and made it successful. Dr. Jaideep, would you like to say something?
Ganga, I want to say something. Ganga and
Sarobi is also there.
I just wanted to compliment John, because I mean, every time I listen to him, I get a complex. I'm not doing as much research as I should be doing. But the point I wanted to make was Southeast Asia has a population of about 700 million. And that's about, say, 10% of the world population. And looking at your map, I realized that there was not much of a dot or a blue in this part of the world. So I'm trying to figure out, even though I'm just a clinician and a surgeon, how I can facilitate and try to take this forward, this collaboration with NEI. And I know GEGC has some activity going on in Singapore. I'm happy to discuss with you offline regarding this, because Indonesia is right next door, and we have close collaborations with Indonesia, routine MOUs, clinical, surgical, educational, research, and so on and so forth. I'd like to talk to you more about that. And maybe your thoughts as well, yeah.
Thank you. Sure. Sure. We'll certainly do that, Dr. Ganga, anytime.
Shushmita and Ashish, thanks for being for the program throughout. Shushmita, you have anything to say?
Thank you so much, sir, Kavita, and everybody for having us here. And I think it was a very informative session, and we covered everything starting from basic research to surgical thing, and also about collaboration. So overall, I think we've done a very good spectrum. It was really nice being a part of this.
Ashish?
Thank you so much, sir. It was really wonderful to be a part of your celebration of 30 years. And it was very interesting to see your talk and see the whole journey. Thank you so much for making us a part of it.
Thank you. Samita?
Yes, sir. So it was a really good experience, and I've been a big part of this journey, and I've seen you since I was a little kid. So I'm very, very proud of what Aditya Jyot has done, and always happy to be associated with everything you do, always.
No, but I have a homework for you. From today onwards, next 1 year, every first of the month, we are going to have a webinar. And every first of the month, which is already done. And also every second Sunday, we are going to have a public webinar to create awareness. So we want you to, whatever you did for my Severity oration, and also recently on the COVID, you did with Ashish, and then later with me and Kavita. Something like that you have to keep doing the whole year as a part of 30 years. So as I said, you, Samita, and me and Kerobi have done 30 years together. Many things, right from Retina to dance. Kerobi?
And you have to unmute yourself.
You're muted.
Yes, I know it's been a wonderful journey with you, Nati. And what I would say is that you've got a very, very, very good, good set of doctors with you who are working along with you, and you always keep up your positivity and your energy for everything.
Thank you. John.
The only comment I wanted to make was what this webinar has unfolded for us is Dr. Natarajan is probably at least around 30 years old. Finally, a little bit of truth is out of the bag.
So, Dr. Natarajan, since you are our family and your family is Aditya Jyoti, I want to share a picture of my grandchild with all of you. I don't know if you can all see, but she's only just a few hours.
Congratulations.
Too much of glare.
Yeah, you have to go still behind. Remy is the name.
Remy Prakash. So introducing her to the rest of the world, actually, to our family, Aditya Jyoti family, and the friends who are sitting here.
Congratulations, John, to you and the parents.
Congratulations, sir.
Gangadhar.
Yes,
if you
Karan.
say he's 30 years old, then probably I went and saw Nati in the ICU. In ICU.
And me and Kerobi do practice at 1 a.m., which is morning in America time. And Amit and Anupam, you are quiet there. Can you
please tell them what practice?
Amit?
Yes, sir.
You have to say something. Commit something for next 30 years.
I was just talking to Hitesh. Few of our panelists, Akshay, me, would have been in just pre-primary kindergarten when Aditya Jyot started. So it's a great thing to join Aditya Jyot as a team of doctors, and hopefully we'll continue for the next 30 years helping each other and the general public in a sense.
No,
Amit, you were in utero.
No, ma'am, not in utero. Not in utero. I calculated. So definitely not in utero.
Yeah, maybe.
Anupam?
Yeah, sir. So today was a wonderful day. Actually, we had a nice session in the morning and this in the afternoon, a wonderful session with all the wonderful panelists. I've been associated with Aditya Jyot for last 14 years, and it has been a wonderful journey. I've seen so many students, consultants come and go, and sir has always been a guiding light and an inspiration to all of us. And all his students, his ex-students, and all are really very lucky to have someone like him. I remember I saw him first time when I was a resident at Miras when sir had come for a conference over there. And we are always known him as a great doctor. And, I never knew that one day I am going to join his own hospital. So it's a wonderful thing, sir. And it's really nice that I've been associated with you and Aditya Jyot. And I'm really happy working there with you and wonderful staff. And they are very, very supportive. Yeah, congratulations and thanks a lot. And hope that you keep us guiding the same way.
Thank you. We can see John's grandchild, Remy Prakash. And I wanted to say Ganga is also related to Lord Shiva. And Jan Prakash also is related to Lord Shiva because he always carries Lord Shiva. And Prakash is related to Aditya Jyot, no? Prakash always. So there is a Remy Prakash and Aditya Jyot go together now. So Remy is the one day and Aditya Jyot is 30 years in one day.
No, she's only 12 hours old at this point.
Yes. Great, John. Thank you very much. And you have
Thank you.
So I especially thank Jaideep and Kavita for doing the program in a great way. Kavita?
We should thank you, sir, for giving us the opportunity.
Yeah, Jaideep, yes.
So I can request everybody to just smile for a picture so I can take.
Okay, yes. So you're taking a group picture?
Yes, this is the group picture of the new normal.
John, this is a nice thing to have young people like them. They do novel things.
Yes.
If I can now request everyone to do a 3-0 so that to represent the 30 years, right hand 3 and this hand. This is great. Thank you. I won't be able to do it, but everyone else can.
Great. That's a great thing. So Samita is a great creative. creative person, and she is a cornea fellow. So she's a cornea surgeon in Pune, and glad we are all together. And thank you very much. I think you will keep doing more.
Thank you, sir. Thank you, Kavita.
Thank you.